Okay, good morning, everyone. Welcome. Today is day 4 of the Peter Wall International Roundtable for Health Literacy. So welcome those who have returned after 3 days of a productive dialogue, and welcome to those who have joined us for the 4th day. And today is our open forum. So it's open to those students and scholars who are interested in health literacy and chronic disease prevention and management. And today we have 9 very informative presentations, and we also have poster presentations that are across the room posted up, and you'll have a chance to take a look at these during the coffee break, and the authors of these posters will also be around in case you have any questions for them as well. So right off the bat, we are going to kick off today with the first set of presentations, and we have 5 of them. So we aren't going to talk any further. I'm going to ask the chair, and that's Andrew Pleasant, who's standing right over here from Canyon Ranch Institute in Arizona, and I'm going to hand it off to him. Thanks, Andrew. And please be careful, there's some wires over here, so those of you who are presenting, just keep that in mind.
It's a little jungle here. Yeah, it's wire literacy. So the moral of that story is if you go over your 15 minutes, we're going to pull the cord, which is my sole job as chair, is to keep people on time. But I just want to say that the last 3 days, it's been a true honor and pleasure to have been invited here from actually outside of Canada. I live and work in the United States and around the world. But, this is a pretty rare event when an institute like the Peter Wall Institute for Advanced Studies invites some of the most critical and sharpest thinkers about health literacy from around the world to spend 3 days together and try to advance the field. So that's been my pleasure and honor, and I just want to say thank you to them. And with no further ado, we will get started. And Mark Fitzgerald, who is being spoken to at the moment, is the first speaker. So please welcome him.
They don't always meet in, I feel like Oprah here, they don't always meet in nice venues like this, usually in airport hotels, and they put together guidelines and then they try to transform clinical practice. And then you go into the real world and you have a Punjabi or Cantonese speaking asthma patient in front of you, and the best evidence-based guidelines in the world seem not to work in that setting. So maybe this is a reflection on some recent data from British Columbia that Mohsen, who will be speaking later, has been involved in. It's a prospective study on the economic burden of asthma, a population-based study in BC, to show that only 25% of patients in BC have controlled asthma. Many have partially controlled, and a significant minority have uncontrolled asthma. So this is one of the challenges with chronic disease. We have effective therapies, but we don't always deliver them. So many people in the room will be familiar with this. So this is sort of a trigger. I think Irv introduced me to this textbook a few years ago when he initially stimulated my 2 neurons to get interested in health literacy. And that triggered this study that I'm going to share with you. And as I say, Raj should really be presenting this. Anyway, we have this arose from a pragmatic issue that we had patients, or I had patients certainly, who I did not have the effective means to communicate with. And to me, this is the ultimate knowledge translation endeavor. It's translating chronic disease management strategies into languages that your patient understands. So with this study, we conducted 4 initial patient focus groups. We developed community and knowledge videos and pictorial pamphlets. Raj presented the just completed study on COPD, which hasn't been published yet, but this study, as you see, has been published. And we were interested in looking at asthma knowledge, practice questionnaires, and then we recruited 85 patients with physician-diagnosed asthma, and they were randomly assigned to 4 experimental groups. And then we conducted these educational interventions. There were 3 in-person assessments and a phone follow-up at the end of the period. And these are just some comments from the focus groups. Can asthma be cured completely? Is it life-threatening? Is asthma hereditary? Will my children get it? I have never received any verbal or written explanation from my doctor, and I've never heard about the action plan. So a primary focus in asthma is to give patients an action plan so they can be empowered to take care of their asthma. I do not know how to properly use my inhaler. My doctor never showed me how to use it. We prescribe $180 combination therapy medications and don't seem to find the time to show patients how to use it. Asthma medications are too expensive. They should be cheaper. Do they have side effects? What are the side effects? I want to learn more information. What are the triggers, etc. I learned a lot from the study. So these were some comments at the end of the study with qualitative follow-up. I think we should have more seminars and lectures in our own language. The community video is attractive and easy to follow, and I enjoyed it. My primary source of health information is my family doctor. And this, many patients find that the most reliable source that they perceive is their physician. So I think we have to empower the physicians to have the skills to communicate the information because they are sort of a trusted and valued member of the health team. So exercise should be avoided for asthma. What type of exercise? A lot of people in my community believe that asthma is a communicable disease, so big issue. A lot of cultural issues around. I want to learn about the peak flow meter and how to use it. So clearly engaging in the dialogue with patients helped us to develop this intervention strategy. And this is just some demographic data. It was sort of mixed half and half Chinese and Punjabi. You can see the gender distribution. There was a significant minority unemployed, retired, probably reflected. This was a convenience sample, so it probably reflected a lot of these patients were recruited from community settings. And these are the characteristics. I think one of the things to really note here is these Punjabi population in particular never attended or only completed elementary school. So 30–40% of patients out there in the wild from these groups had no fundamentally education. So we approach them with our technical jargon, which is full of inflammation and, you know, all these terms that are totally gobbledygook. The age groups, so again, reflecting the convenience sample, they tend to be older. And just to show you, without going in great detail, there were various parameters that we did pre-test and post-test and follow-up, and various questions around knowledge. And because we don't have a lot of time, I'm not going to show it in detail, but just to say that the intervention was very successful. And we didn't do this intervention to look at health outcomes because clearly it's not powered, but we know from other control trials in larger populations, looking at if you improve a patient's knowledge about their asthma, their confidence level about dealing with their asthma, those health outcomes improve also. And this is just to show you some issues around the different groups. So I guess one of the issues we wanted to see was, if you view the knowledge video, the community video, or both of them, or just got an educational pamphlet, would, for example, the videos be more successful? And there were some outcomes that were more successful, particularly with the community video. But overall, if you even have written material that's appropriately geared from a health literacy point of view and has an ethnicity consideration within it, you see improvements. And I'm going to quickly go through this because, anyway, to show you that across intervention groups, educational gender groups, you can see here, I'm going to go through this very quickly because time is of the essence. So we showed in this intervention that we changed knowledge about asthma management, and we showed that language and culture can be important barriers to assessing, understanding, and using asthma information. And appropriately developed education materials can lead to increased knowledge over time with regard to asthma. And I should mention, in terms of knowledge translation, I have a collaboration in Shanghai, and Dr. CX Bai there is considering using our Cantonese and Mandarin educational videos developed in Vancouver in a citywide intervention in Shanghai for asthma education. So I think that's the ultimate CIHR knowledge translation intervention. So I just finished with this. When I talk to physicians about education and about medication and asthma, I put up this slide. I think I mentioned this in one of the workshops yesterday about the blockbuster drug. This maybe is a bit overstated, maybe it should be intervention, but there's a 65% reduction in hospitalizations with asthma education, and there's a 45% reduction in ED visits. So it's not rocket science. And I think, as I said to people yesterday, if I had the patent on this intervention, much as I like being here with you nice people, I'd be in the Cayman Islands or somewhere collecting royalties. It actually achieves better outcomes than any other $25,000 a year monoclonal antibody intervention in asthma. So I think it's something that we overlook. And for me, who's a clinician in chronic disease management, we have achieved a lot, but I think we're interested in taking the next step in a multicultural, multi-ethnic population. So somebody referred yesterday or 2 days ago to the Peter House inhaler technique video. So if you want to sort of, if you want to amuse yourself, you should go on YouTube and Google Peter House, and you'll watch this lady inappropriately applying her inhaler to below both jaws. I had a German lady a few years ago, and she took out her inhaler technique and she did all the right steps. And I explained to her that you had to take the top off. So we took the top off, and it was beautifully layered with inhaled corticosteroids. And she was very angry because she was a German lady. And she said, nobody ever showed me how to take the cap off. So here we have this lady taking this medication at $150 ago. And I had another patient who came to see me, and he held out his inhaler literally like this. And there is a variation on inhaling, which is called an open mouth technique, where you just sort of hold it to. He literally held it out here. So he was from northern BC, and I think there's a big ozone-depleted layer in BC because all his... So effective strategies are available for the majority of asthma patients. There's a major problem with adherence, which Mohsen actually is here, could give you a nice presentation in terms of BC. To me, health literacy is a major problem. I think we're interested in developing strategies for improving this. And in multicultural society, education events need to take account of diversity. And I'll finish with this. Don't be silly. Everyone up here smokes. We're already dead. So, thank you.
Thank you. Okay. Hi, everybody. My name is Mohsen. I'm an assistant professor of health economics and outcome sciences in Division of Respiratory Medicine, working closely with Mark and Iraj. And this is a joint presentation with my colleague and mentor, Dr. Sterling Bryan, who is an associate prof at the School of Public Health at UBC. So we are talking about economic aspects of health literacy. I have to make a confession here. It's a little bit of humbling experience to talk about economics and health literacy in a room that is, we have economists here working full-time on health literacy, and we have a lot of health literacy experts. So please don't shoot me if I am saying mistakenly or I have making blanket statement and so on. So the mini outline of our presentation is about economic aspects of health literacy, and mainly on these two parts. Intersection of economics and health literacy, to my opinion, comes down to two important considerations. First, what is the economic burden of low health literacy and the concept around quantifying that measure. And the other one is that, okay, when we want to improve health literacy through some interventions, what are economic considerations in implementing those interventions? So I thought these are two important intersections of health literacy and health economics. And in order to have a good understanding of these two concepts, I think we should have a basic understanding of the production process in healthcare. This is a very simple slide, almost an oversimplification of how the healthcare system in our countries work. First of all, we have health capital, which is our health. Health is a goods in economics, just like our properties, assets, money that we have in bank accounts. So we all have a stock of health. It is subject to increase and decrease. It's very difficult to measure, but no dispute that it's there. And the job of the healthcare system is, through programs and intervention, to hopefully increase the health capital across the individual and as a whole across the population. And of course, there is cost associated with that. It's called the healthcare cost. What we do in healthcare is that we spend resources mainly in two terms, labor and capital. Labor, of course, is the human force. Big in the muscle force is the brain force, the typical like white collar, blue collar paradigm. And capital, the dollar that we spend in the healthcare system. Using these resources, we implement programs and interventions. And I want you to think very broadly when we talk about programs and intervention. It could be anything. It could be vaccination for in childhood. It could be a screening for colon cancer. It could be treatment for asthma and COPD and diabetes and hypertension. Even outside of the healthcare sector, it could be, for example, fitness centers across the city. We are using money from the public or private sector. These are programs and intervention, and we are hopeful that we can increase the health capital and reduce the healthcare cost. This is a paradigm of a healthcare system. This arrow called the healthcare production process, and this one is called health production process. So I was thinking of where to put health literacy here, and I hope you will agree with me that a good place to put it is in here. Health literacy is kind of a bottleneck affecting the effectiveness of program and intervention through their uptake by the individuals. It can be seen as a rate limiting process. I see it as like a lasso around the neck of somebody that you try to feed that person. If it's too tight, the person cannot eat despite the fact that there's tons of food in front of them. So if you have programs and intervention, but individuals are not able to update them, then they will not be effective. They will be tremendous waste of our resources here. This is the concept that Grossman in 1972 put it, health capital production, producing good health through health literacy. So it's one aspect of seeing health literacy in the healthcare system. Now, with this lens, we can conceptualize the economic burden of low health literacy. It's equal to opportunity cost in not producing good health despite spending capital and labor. Again, it's like a difference between two scenarios when everybody is fully health literate. I don't know if it is even theoretically possible, versus the cost of the healthcare system when people at the current level of health literacy. The difference between the two is the economic burden of the low health literacy. And of course, low health literacy levels may lead to vast inefficiencies in the production of health capital. Some people have actually tried to measure that. Measuring the burden of chronic diseases is rather a standard practice in health economics. There are tons of papers, publication reports, measuring the economic burden of asthma, COPD, diabetes, hypertension, and so on. But very few have measured the economic burden of health literacy. And I think I have a, sorry. And I think I have a good understanding. It's because of the vast implications of low health literacy. It basically translates into many health conditions. It is not restricted to within one or two discrete health conditions. That's why it becomes very difficult to measure. So these are a few studies. I got it from this relatively recent systematic review. Studies have done this at the aggregate level and at the individual level. Aggregate level is across the whole nation, mainly US and also Switzerland, and some other countries, just a selection. And individual level, again, mainly in the US. Typical study is 2007 is the most methodologically sound study in the review. And they use this survey, you might be more familiar with it than I am, National Assessment of Adult Literacy. It's one of the first surveys in the US that had a health literacy index incorporated into that. So the authors translated the level of health literacy to the medical expenditure, adjusted for confounding variables, and estimated the cost of health literacy in the US to be around 106 in the lower bound to $203 billion. To put this in context, Mark, your disease, asthma, I think in 2007 cost $56 billion to the US economy. One of your diseases that you want to be there. And if you consider the downstream cost, it actually goes up to $1.6 to $3.6 trillion. This is a very large number. We are talking about significant amount. And this is equal to insuring all US population. So removing the problem of lack of insurance across the US. That's a good measure of putting it in context. Again, across the individual, it's quite varied, but still from $143 to more than $1,000, $7,000, depending on the methodology, it's rather difficult to measure. It's a very complicated concept. And okay, the second way of putting health literacy in this context is to see it as a program or intervention. No, again, the other objective of this presentation. No, we want to improve health literacy in order to reduce healthcare costs and increase health capital. So it's itself subject to being implemented, subject to a spending of resources, and in this sense, it competes with all other interventions that we have across the health sector. And of course, the problem is that we have too few resources and too many programs and intervention. So in this situation, we have to be efficient. What does it mean to be efficient? It means that we have to spend our resources in a smart way to maximize the health capital and reduce the healthcare costs given a constrained resources. The health capital is usually referred to as effectiveness of an intervention. Costs are usually cost. So the analysis that informing that efficiency question is called cost effectiveness analysis. And from now on, I'm going to hand it to my colleague Sterling to take the rest of it.
Thank you very much, Mohsen. So I'm not going to say very much more, I don't think. I'm just going to try and build upon what Mohsen has said and talk about cost effectiveness. So what do we mean by cost effectiveness analysis, and how might this be applied in the context of health literacy? 7. Okay, 7. Is that The number of minutes I have left, I guess. Yeah, right. Okay. Cost effectiveness analysis is applied pretty generally in healthcare to make judgments about uptake and reimbursement of healthcare technologies typically. And in that context, it's relatively straightforward. I mean, it's not simple, but it's relatively straightforward. If we think about a drug or a device, we can evaluate a drug or a device in terms of its cost and in terms of its benefits. And so we look at program costs. We also try and look at downstream costs. So if we have savings that might accrue, if we've got an effective intervention, we're going to presumably be saving future healthcare episodes, hospitalizations, etc. And we think about effectiveness in terms of improvements in health-related quality of life and improvements in survival, which we, as health economists, try and put into a single number, the quality adjusted life year. Because we like things simple. It's gone up to 10. Right, okay. Okay. I'll go with about 8.5. Okay. I won't need that. So the thing to remember about health economists is that we're trying to put a single number on everything. So like we like it simple. So we're trying to aggregate everything to be a single number. So we want the cost effectiveness analysis to come up with this acronym that we have, ICER, the incremental cost effectiveness ratio, which is something I'll try and explain using this diagram. So typically what we do, so have we got a point? No, oh, that's not it. Yeah, pointer, right. So typically what we do, we start off with this diagram, we say the intersection of these two axes is where we currently are. So currently we have a problem in terms of poor health literacy. So this is our current scenario, and we have an intervention. And we want to try and improve health literacy, or we have a drug that we want to try and sell, and so we have the opportunity to provide some benefits. So hopefully our intervention is going to be effective, and so we're going to be in the east part of this diagram. We're either going to be in the northeast or the southeast if we have an effective intervention. And we hope that we're going to see something that is effective. And then what we want to try and establish is, are we going to see an increase in cost, or are we going to see a reduction in cost overall? And of course, for most interventions, we're going to be in the northeast quadrant. Most new interventions take us to the northeast quadrant. We're going to have to find some additional resource, and we're going to have to we're going to want to experience improvements in health-related quality of life and survival. So typically, we're in the northeast quadrant. And we have to make a judgment if we're in the northeast quadrant. Is the magnitude of the benefit that we're going to see worth the increasing cost that we're going to have to pay for it? And that's what the incremental cost effectiveness ratio provides you. It's a judgment. It says that we might have to pay an extra $10,000 in order to receive one additional quality adjusted life year. And that gives us a sort of a metric of value. And typically what we're looking at in health economics is this notion of value. Are we actually getting value for money? And value is the central thing that we're trying to establish. So consistent with what Mohsen was saying, we're thinking that health literacy has got two ways of promoting value. So from an economics point of view. And one of those is as a facilitator of value. So this is when Mohsen was using this rather graphic description of someone with a noose around their neck, where someone's trying to eat, but they're struggling to eat because they have a noose around their neck, which is the health literacy challenge. So what we can do by providing improvements in health literacy is increase value for the current investments. So where people are currently using therapies that we believe are cost-effective therapies, but there are impediments to the value that they're receiving because of their health literacy, then we can see health literacy as a facilitator to value. So it's going to potentially improve the cost effectiveness of what we're currently doing if we can improve health literacy. And then the second piece that Mohsen talked about was health literacy as a value proposition in its own right. So these are interventions to improve health literacy, and they're going to be interventions that themselves represent value. So this would be sorts of things where we're promoting self-management. So an intervention that's promoting self-management potentially is improving health literacy and has intrinsic value in its own right. It's providing benefits that may not even be seen in terms of health improvements, but broader welfare benefits to an individual in terms of improving their overall life experience might be something that would fall into that sort of category. So from an economics point of view, I think we're trying to see health literacy both in terms of this facilitator role, but also in terms of something that can provide value in its own right. And what the economics is trying to do is trying to establish what the magnitude of that value is. Do these represent investments that we should be willing to pay for or not? Because an economist comes at this in a neutral way. I'm not interested in asthma, I'm not interested in health literacy, I'm interested in value. So what can we get that's going to be valuable? Okay, just to finish off, some of the challenges. So this isn't going to be easy in health literacy in particular for various reasons. We've got interventions that are multifaceted and that require long spans of time for the benefits to materialize potentially. This is not going to be a quick win in terms of providing benefits. That in itself provides enormous challenges because we then have to try and extrapolate and predict what the long-term profile might end up being. So I'm going to just then go to some conclusions. So inevitably, we're going to have to do economic analyses. If you want to get influence in policy, then you've got to talk to policymakers about both costs and benefits. And the cost piece at the moment is particularly important, of course. There is a tremendous economic loss, and I think it's undoubted that there's an economic loss associated with health literacy, although it's not been very well studied. And we see very little by way of economic evaluations of health literacy programs, but that's changing. And certainly the work that has been shared at this meeting tells us that we're moving in the right direction. So thank you very much.
All right, okay, thank you. And thanks for the opportunity to share some of the work I'm doing in using telehealth to provide chronic disease management to patients at a distance. So just to start the scene off, so let's say you're a patient in Vancouver and you want to see this cardiologist at St. Paul's Hospital. That's not a big deal because St. Paul's is right around here. VGH is, I guess, somewhere here would be? Yeah. We tend, even though we're pretty close, there tends to be some sort of rivalry. This patch of water might as well be like the English Channel. Say if you live in Whistler, here, it's an hour-and-a-half drive to Vancouver, and you could see the cardiologist, and we have plenty of patients who come into the program, see a cardiologist, attend cardiac rehab programs. Not as many because they're driving, it's a 3-hour return trip. But let's say you live in Fort St. John, and for those people who don't live in BC, or even like me, don't really know until you looked it up where Fort St. John was, it's about a 15-hour drive from Vancouver. And you could take the plane to come into Vancouver. The closest cardiologist to this town is in Prince George, which is about 4 or 5 hour drive away. And it was only till recently that they got a cardiologist. Up until 2 years ago, they were internists who specialized in cardiovascular medicine. So this actually presents a barrier to services. And that barrier is one of the reasons for this difference, where we see hospitalizations stratified by where people live, the rural area and urban areas. And per capita hospitalizations for a variety of chronic diseases is higher in rural areas. And in part, this is due to a lack of access to service, access to specialty care, access to things like cardiac rehab programs, lung clinics, diabetes teaching centers, and so forth. So that prompted us to start up a group called the British Columbia Alliance on Telehealth Policy and Research, and established in 2005. And we have representation from each of the 6 health authorities in the province, as well as 3 of the 4 main universities. And the idea here is to bring researchers and decision makers and healthcare providers together to develop and evaluate internet-based interventions for chronic disease management. So the first thing, especially on my grants when it came back for review, is, well, not everybody has internet access. And so we had to work a case of why this is still important to push through. I couldn't really respond and say, well, it's better to give 50% of the people some care as opposed to 100% of the people zero care. That probably wouldn't have gone over too well. But if we look at internet access in Canada, we see it's increasing. This is stratified by age. So less than 35 years of age here, and over 65 and older here. And what we're seeing, and one could argue that actually it's accelerating more at the lower age groups because they have a higher capacity to increase. But we do notice that age is related, as other things, to decreasing internet access. And I would argue that most of this is a cohort effect as opposed to an age effect. There will be some decay in internet use as people age, but these people in this group didn't grow up with the internet. But when we see these people getting to the same age, we'll see greater internet access and use. But this is still our target population for now. And we wanted to drill deeper and see what the actual use and access, because access can be one thing, but uptake and use of it can be another. So we surveyed about 300 cardiac inpatients from 2 hospitals, one at St. Paul's Hospital, which has about 40% of their cardiac patients come from outside the Vancouver area, and then the regional hospital in Prince George. And so we're happy because what we wanted to do is make sure that we got representation outside of Vancouver, because this is where we see the greatest benefit to be. So 2/3 were outside of the greater Vancouver area. Of the 300, 3/4 had a computer at home, and then 2/3 of them had home internet access. And then most of it was high speed. And we asked a number of questions to glean some information on uptake and whether if we build it, will it be possible to use. So this isn't all that surprising. It's similar to other literature that centrist metro area would be like the greater Vancouver area. This agglomeration area would be a town like Prince George, has about 100,000 people. And then rural area in Canada is basically anything that doesn't fit into these two. So access to the internet declined as you move to smaller areas. And this, one would think like these people would want to be connected more, but it speaks to the point that the people that we think or the people that might benefit from any type of intervention are the ones that tend to be the hardest to reach. We asked questions on who the main user was, because you could have it at home, but it doesn't mean that that person is actually the one using it. So the majority was the patient, and I've stratified this based on the total cohort, and then NHA stands for Northern Health Authority, because this is where we're looking, and it's basically the top northern part of British Columbia. This is where we're trying to target our interventions. Then partner and children and other. So the person that we were talking to at the time in the survey was the main user. We asked them the questions of what they were using it for, and we used the same categories that at the time was the Stats Canada Health Internet Use Survey, and so browsing, email, health. And so same as the Stats Canada survey is health. Seeking health information was the 3rd most identifiable reason for using the internet. And one could argue that browsing is just kind of general in the email. This is the first kind of specific reason. It beat out things like vacation planning, online banking, and in here is online gambling that some of the participants participated in here. Some of these cardiac inpatients had cardiovascular disease before we did the survey, before their admission, but others did not. So it wasn't just a case of that they were accessing health because they were sick previously to the survey. Then how often did they access the internet? Because if we want to create an interactive system, what's their current pattern of behavior? Are we asking them to do something different than what they're used to? And so over half indicated that they are using it daily, and then another 20% greater than once a week. So about 70% of patients were saying that they were using it greater than once a week, multiple times per week. So that set us off on the next stage. And we've done a number of projects since. We've interviewed patients, decision makers, providers, on shared care, readiness. We've done a couple of programs, but I want to concentrate on this one, the multi-chronic disease program, for the rest of the time that I have. And so we call this My Health Connect. And one of the reasons is we went to multi-chronic diseases. When we started doing our studies is that as time's going on, it's hard to actually enroll patients for if they, just for let's say heart failure, and you don't want anybody with comorbidities. It's getting pretty rare to do that. And also one of the people on the team was saying, well, we don't want a website for every single disease. And this also can potentially help with coordination of care. There's common modalities in terms of risk management and supporting patients in their self-management. So this is it's a supervised self-management patient monitoring in coordination with family physicians. So that's one of the key things here as well, is trying to, in order to make this, to increase the uptake, is building it into current practices instead of what a number of interventions previously have been described as carved out of primary care. And we've actually used the family physician as the point of recruitment. And we're currently doing the study, recruiting patients with ischemic heart disease, heart failure, diabetes, chronic kidney disease, COPD, and they have to have internet access. Could be at home, could be at work. They don't have to also be the one using it. They can have a care provider. So we have a couple patients who are doing it that way. They have to have 2 or more of these conditions as well, and then it's a randomized study, and we follow them for 2 years. Our main outcome is hospital admissions, but we have questionnaires to look at quality of life, social support, change in self-management, provider satisfaction, because provider uptake is extremely important, and then healthcare utilization. So before we embarked on developing it, we put together an advisory committee of specialists, allied healthcare professionals, as well as family physicians from outlying areas, and then patient representatives, so who actually met our study criteria to actually participate and pilot test it before we rolled it out for the study. So the basis of our program is that patients will regularly enter data and then respond to symptom questions. And these are questions that are specific to their disease. And I'll get into that in a moment. And questions that might be indicative of changes in their progression or improvement in their disease. And then there's alerts based on their answer. If there's no alerts, if it's all within the desired range, they continue regular monitoring. Now we have defaults set throughout this, so if somebody starts on the program, they would be prompted to enter data every day for a week, and then, but that can be changed. And if they're stable, they would only be, they could go down to once a week data entry. And then there's email alerts that will be sent to them. They can sign up for it to remind them. If there's an alert, it's sent to an email sent to the nurse. And this is another key part that I'm going to show you a few web pages, but this is a key part here. The nurse is phoning the patient and talking to them about reinforcement self-management, behavioral change as well, and may refer, if needed, to their family physician for medical management. And if this is working, then that same patient would actually likely have less alerts going forward. So I'll just go through the patient interface. And we had a number of different designs. And when the patients who tried it out came back and they directed us on what they felt was the most comfortable design. And so it's a yes or no question. If they answer yes, then they come up with this Likert scale. And then if a patient answers much worse to one of the questions, that sends an alert, or a little worse to a couple of the questions, that'll also send an alert. There's also, if they're diabetic, for example, we also track weight and blood pressure. And at the end, they can get a summary of before they submit, and have opportunity to change and see where they've answered yes or no, and their physical measures. There's a home page that they get to. There's also a lifestyle report that comes up that's cross-cutting to recognize that lifestyle behaviors factor into this, and progress and action plan. So the progress graphs are meant to demonstrate to the patient how their physical measures and their symptoms can go together. And the nurse can also, on the phone, direct the patient to this. And where they have these red circles is where they've generated alerts. It could be because of the measures outside of the target range, or it could be because of symptoms. And over time, in our pilot studies in heart failure, the patients started to recognize how their weight was associated, changes in their weight was associated with how they feel. This is an action plan that is developed between the patient and the nurse over the telephone, and then the nurse transcribes this in. Some of it's around behavioral counseling, and some of it's around what to do in, let's say, in this case, if their blood sugar goes above certain levels. It can be printed and then taken to the doctor as well, who can authorize it. So this is some of the feedback that we've got to date. This one here really helps me stay on track. This one here, this was from a patient who, during the Christmas holidays, and the nurse wasn't working during that time, but was able to take that action plan and follow what they're doing when they measured their home blood pressure, and it was quite high. It was, I think, 190 or plus. And then they took the action plan, went into their doctor. They were pleased, for one, that they knew what they were doing because they had that action plan, and two, that they were able to actually communicate to the physician. And the patient was highlighted that the doctor actually listened, because before they weren't able to communicate. And this is one of the pilot study patients who helped in the design and sent an email to us saying this is that they found it very helpful, and the pilot patient is still actually participating in this. So just want to end off with one caveat. I'm obviously enthusiastic about this type of medium for providing access to patients. But it's not going to be the panacea, because no matter what we do, there'll still be this digital divide, people who have access and don't. And so some of the things that we're looking at are actually translating this into a telephone intervention that can phone patients through voice recognition or touch tone dial-up. They can answer the questions as well. And I'd just like to thank the partners that have been essential in actually getting this study rolled out and also providing input into its design. Thanks.
Thanks very much, and thank you very much for inviting me to this health literacy roundtable international meeting. And what I'm going to talk about today is cardiac disease in ethnic groups and how this might link to health literacy. So we know that Canada's population, really the Western populations are changing. And we're seeing that the immigrant population in Canada is increasing dramatically. In particular, the South Asian and Chinese populations are amongst the largest and most rapidly growing populations. By 2030, it's estimated that at least 1 out of every 11 people in the country will be South Asian. So that's really changing the demographic, which has substantial implications for healthcare. If we were to look at heart attack rates or heart disease rates in the province of British Columbia, we'll see the blue bars are the South Asians, and the red is Chinese, and yellow is the general population. So we see that South Asian patients in particular have very high and substantial rates of heart disease, and same in men and women of that ethnic group. Now the thing is that most people survive heart attacks. So these people will actually spend the rest of their lives managing their heart disease. And we know that South Asians in particular get heart disease about 5 to 10 years earlier than the general population. So that's a lot longer period of time in the healthcare system managing their heart disease. And I'm sure you've seen this statistic many times at this meeting, but we know that the majority of immigrants that come don't have sufficient health literacy for everyday life, and certainly for managing their diseases, complex diseases like heart disease. Now, how might health literacy impact chronic cardiac management? So they won't be able to have sufficient understanding of written medical information, follow instructions, ask questions about treatment, communicate about ongoing healthcare concerns. And what could be the implications of this? Well, they could have lack of understanding of their cardiac disease management, cardiac symptoms. This could translate into lower access to healthcare services. So that could include emergency services, hospitalizations, as well as deficiencies in healthcare-related skills, like medication taking behaviors. That's a major part of disease management for most of the chronic diseases in Canada, and again, a major therapy for heart disease. and as well lower disease outcomes and satisfaction with quality of care. So my research has looked at from onset of symptoms all the way to outcomes, and I'm going to talk to you about certain aspects of the research that we've done in evaluating chronic disease management of the cardiac patient. So basically, patients will come into a hospital if they have heart attack symptoms, they'll see the doctor, get interventions, and then from there on, they'll be seeing their family doctor, they'll be prescribed medications, they'll take the medications, and they'll get regular follow-up from then on. So that's the essential care pathway. So if we looked at emergency care in South Asian, Chinese, and white patients, and this was in a pilot study of 100 European descent Chinese and South Asian. And what we found was that their time from onset of symptoms to arriving at the emergency department was significantly lower in the ethnic groups. We also found that of those patients, the patients that came in with heart attacks, 76% of Chinese did not speak English, and 55% of South Asians did not speak English. Not only were they late, but they did bring in, about 98% of them at least waited to bring somebody who did speak English into their interview. So the vast majority did come to the hospital with somebody who spoke English. And the other thing that we found was that when they were telling the doctor about their symptoms, like the classic symptom of heart attack would be chest pain. I think everybody knows that. But South Asian and Chinese patients were less likely to actually say those words, that they were having chest pain. And we don't know if it's because they truly aren't having more chest pain, or that's not the words that they would use, so it's not picked up. And this is some of the data that shows that their time to arrival was lower. And we also found that when Chinese and South Asian patients had their heart attack symptoms at home, they did not come to the hospital right away. They did not take an ambulance. They waited to go see another doctor before they came to the hospital. And we don't know if this is sort of what you found, Mark, in your study, that they had a doctor who spoke the same language, they could understand, the doctor could understand them, and that they would have this intermediary step before coming to the hospital. But we know that for heart attacks, time is muscle, so people have to come in as quickly as possible. So we looked at, once they arrived in hospital, what kinds of care did they accept? So this is a study we did on invasive procedures. So this is like angiograms, bypass surgery. These are really invasive procedures. And it turns out that South Asian and Chinese populations were just as likely, if not more likely, to get these procedures. So they were willing to have these procedures done. And these are major invasive procedures. Then we looked at what happens when the people go home, and now it's up to them to take their medications. And we found out that their prescribing was more or the same as the general population for life-saving treatments. But when they got home, they were much less likely to take their life-saving medications up to a year. And this is after a heart attack. We've done a similar study looking at diabetes patients where it's, you could probably argue, not so grave as after you've had a heart attack to take your medications. And there were substantially lower rates of taking medications after they'd have diabetes or a heart attack. So we also know from other studies that they're less likely to participate in cardiac rehab programs and exercise programs. So we're seeing that things break down when people go home. And we could think that maybe part of this is at least due to issues of health literacy. So when we've done qualitative studies to look at what are the barriers to cardiac care after having a heart attack, they've noted that language barriers are still a major issue for them adopting appropriate cardiac care. And we know that there are lower levels of health literacy. We know that there are lower levels of awareness, general knowledge, socioeconomic disadvantage, and maybe preference for non-Western therapies as well. So there is some cultural context that comes in to their understanding of health. And as well, fundamentally differing beliefs about medication or about treatments and disease. So for example, South Asians felt that after they'd had a heart attack, that it was done. It's like having pneumonia, you get over it. And what they didn't understand is that after having a heart attack, you still have heart disease. You don't get cured of it after you go home. So there was a fundamental difference in understanding, and I think this has implications for when we look at health literacy in these populations. So we've launched a series of studies, and I'm not going to give all the details about the study, but they're drilling into some of these issues, looking at language proficiencies, looking at knowledge, where their sources of information is from, what role do families and translators play in their cardiac disease management. But one thing that we did was when we were trying to do a study to try to elicit what are their heart symptoms, we thought it would be fairly straightforward. We had employed a cross-cultural adaptation approach. So we would give all of our materials, we would translate it, have it translated by ethnic groups, make sure that they understood the words, semantic meaning, and then translate it back. We also had pictures. And so oftentimes when you ask patients about heart attack symptoms, you ask, does it feel like you're an elephant sitting on your chest? Does it feel like a squeezing pain? And even the pictures of what does things like squeezing pain mean to you were different in the different ethnic groups. So we found, for example, we found this very interesting. So squeezing for South Asians was more like this. This was squeezing for them, but for the Chinese population, squeezing was ringing. So even in pictures, there's differences in understanding and cultural context. So this was really eye-opening for us. So we're looking forward to seeing the results of our study that we've enrolled 900 patients across the country so far, and we're looking at their disease management, their cardiac behaviors, and their knowledge, issues of language barriers, their medications, what are their beliefs about medications, the cultural impact, complementary medication use, and some mediators and moderators of health literacy. Thank you very much.
All right, so the title of my talk is a little bit misleading in that I'm going to be focusing more on peer leader training, which is the step before actually conducting a peer support intervention. So I'd like to start by saying I'm an American who is proud and thrilled to live in Canada. So what I appreciate the most about the Canadian healthcare system is that no matter who you are or how much money you make, you can waltz into any medical clinic, show your trusty care card, and see a doctor in under 30 minutes, just as fast as dominoes. But that's not the best part. So the best part is you don't have to fill out any paperwork at all, and you never receive a bill. And you can see a doctor as often as you like, every day even, if that's how you choose to spend your time. So that being said, there are some similarities between US and Canada, particularly as it relates to diabetes care. So when we talk about diabetes self-care, we really should be talking about a continuum that starts with diabetes self-management education and evolves into ongoing long-term diabetes self-management support. So both the US and Canadian healthcare system is really good at the first part of the continuum, but they're not so great at the second. And the study I'm going to be talking about today is going to address that issue. So we know from overwhelming evidence that self-management education programs are effective in improving diabetes-related health outcomes. But the problem is, without continued follow-up and support, these short-term improvements that our patients make are not sustained over the long term. So what we need is an effective model to help patients transition from the clinic setting to the community setting, stay motivated, and maintain the lifestyle changes they've already made, all while not increasing healthcare cost or provider time. And I think that this model could be peer support. So in the context of healthcare, Dennis puts forth this definition of peer support. Now, peer support can vary substantially with regard to who, what, and how it's delivered. In fact, there are A variety of terms used to describe people who provide peer support. They include community health worker, lay leader, promotoras, patient navigator, et cetera. But for the purposes of this study, I'm going to be using the term peer leader. Peer support studies also differ in how they define a peer. Some studies require that peer leaders have type 2 diabetes, while other studies allow caregivers to serve as a peer leader. And there are even some studies that not only require that peer leaders have type 2 diabetes, but that their diabetes is under good control, so under 8% or 7.5. There are a lot of different ways to provide peer support, and it can be delivered in many ways. And I think the ones that we're most familiar with are face-to-face in a group-based setting, individual-based peer-to-participant, individual-based peer-to-peer, telephone-based, web-based, text-based, or integration of any of these models. So while there are a lot of differences in who, what, and how peer support is delivered, it's important to note that the basic key functions of peer support are the same across programs. And that's programs regionally, nationally, and even globally. Function 1 is assisting patients with the day-to-day management of diabetes. This can include helping patients set behavioral goals, develop action plans, and problem solve. Function 2 is providing emotional support. This can include providing encouragement, listening without judgment, or helping patients cope with stress and depression. Function 3 is linking patients to clinical care. This can include helping patients access the healthcare system, navigate the healthcare system, or serve as their own advocate. And function 4 is providing support that's flexible, easily accessible, and ongoing with no expiration date. So given this overview of peer support, it's clear, at least to me, that peer leaders can play an important and complementary role on the self-care continuum. Specifically, they can pick up where the health professionals leave off. The question is, can we actually train peers to do that? So the objective of this study was to determine the feasibility of developing a program training peers to facilitate self-management support interventions, specifically an intervention called PLEASED. And PLEASED stands for Peer-Led Empowerment-Based Approach to Self-Management Efforts in Diabetes. I think every researcher has, in their career, has one chance to make a really great acronym. So this is mine, so it's gonna go downhill from now. So feasibility, how did we define it? The ability to recruit at least 8 peer leader candidates, the ability to maintain an attendance rate of 80%, and the ability to graduate and recruit or retain 4 peer leaders that meet the pre-established competency criteria for graduation. So to be eligible, candidates had to meet these basic inclusion criteria. So interestingly, in my previous studies that I've conducted with the African American and Latino community in Michigan, one of the criteria was that you had to have type 2 diabetes. And the reason we did that is because in focus groups, that was very important to those 2 groups. However, with the Punjabi-speaking South Asian community, what we heard in our focus groups was that it wasn't important that the peer leaders have type 2 diabetes as long as they were really well trained, which was fortunate for us because it was really difficult to recruit folks who had type 2 diabetes to be peer leaders. So of the multiple strategies we used for recruitment, 4 of our peer leaders were recruited, 4 out of 10 were recruited from the Surrey Leader newspaper, 4 were recruited word of mouth, and then 2 were recruited from flyers posted on temples and local businesses. So the peer leader training was a 5-week program. It was conducted in March 2012. The training program it lasted over 5 weeks, consecutive Saturdays, and each training session was 4 hours in length. So altogether, it was a 20-hour training program. So the program was conducted at the Kwantlen Community College, which was free of cost to us, and it was delivered by a team of 6 educators. And the team included Salima Wali, a pharmacy educator, Raj Sohi, a nurse educator, Manorma Bhatti, a dietitian educator, Harmeet Mundra, a dietitian educator, Sandeep Batha, a dietitian educator, and myself, a psychologist educator. So the program consists of two major components that are integrated within each training session. Component one is developing effective communication, facilitation, and behavior change skills. And component two is taking these, practicing and applying these newly acquired skills in experiential learning scenarios. We also use a wide variety of teaching approaches, which I'm going to be explaining in greater detail shortly. But to show you how we integrated the program components and the teaching approaches within each training session, I'm going to walk us through a sample session. So this is session 1 of the 5-session program. And in that box, you see the learning objectives. And as you can see, we address both program components, which is the skills development and the skills application. So at the beginning of every training session, we administer a quiz. And the purpose of the quiz is to help trainees really reinforce the information and the skills they learned in the previous session. The quizzes are self-graded, they're not turned in, so it really serves more as a teaching tool rather than an assessment tool. In this skills building session, we're focusing on the skill of making reflections. Typically, the trainers will describe what the skill is, model the skill, and then facilitate a series of exercises that help trainees develop the skill. Role-playing is just one of the learning formats that trainees use to develop and practice their newly acquired skills. After each interaction, the trainees will debrief with one another using an objective rating form. Group brainstorming invites trainees to generate responses, examples, and ideas to questions posed by trainers. And this is a picture of two of our trainees, John and Manjul, who are engaged in a role play. So group sharing is different than group brainstorming in that it invites trainees to really share their personal thoughts, feelings, and experiences rather than just generate objective responses. So in this type of activity, we're really trying to tap into the emotional and psychosocial aspects of living with diabetes or caring for someone who lives for diabetes. And finally, at the end of each training session, we have the trainees work with one another to set a behavioral goal and to develop an action plan, or I call it a behavioral experiment. And the reason we do this is because these are the two most important behavior change skills that peer leaders are going to be using with their participants. So to successfully graduate from the training program, trainees must achieve the pre-established competency criteria for these 4 domains. To assess active listening skills, we use a standardized patient exercise. Specifically, we instruct the trainee to facilitate a values clarification exercise with the patient. And all that means is that the trainee is going to elicit from the patient's most important personal values and how that really connects with their current self-management behavior. So to pass, trainees must achieve a mean score of 4 or greater on the active listening observation scale. To assess empowerment-based facilitation, we developed a series of video vignettes of real patients making typical self-management statements. So we instruct the trainees to listen to the statements and then write a 1 to 2 sentence response. Responses that really explore the patient's problem or their feelings earn the highest points. Responses that express judgment of the patient would earn the lowest points. So for example, if a patient were to say, I had 6 large roti this morning, and the peer leader responded, well, how did you feel after you ate that? They would earn +2 points because it really tries to tap into the patient's feelings. Alternatively, if the peer leader says, well, you wonder why you're so fat, that would earn them -2 points. And you might think that's funny, but my mother would say that, so I know it happens. Chinese people do that. They're very blunt. To pass, trainees must score a +2 on 3 of the 6 vignettes and at least a +1 on the 3 remaining vignettes. To pass behavioral goal setting, to assess it, participants must, we do another standardized patient exercise, and this is where we instruct the trainee to work with the patient in setting a behavioral goal and then again developing an action plan or a behavioral experiment. And to pass, trainees must achieve a 4 or greater on each of the goal-setting steps. To assess self-efficacy, we use a 6-item inventory that addresses the core communication and behavior change skills that we expect all trainees to be confident in performing at the end of the training program. And to pass, they must score at least a 4 or greater on each of the skill items. Okay. So our goal was to recruit 8 peer leader candidates, and we recruited 10. 2 of our 10 candidates didn't show up on the very first day of training, so we really just had 8. Our attendance rate was excellent. Of the 5 training sessions, only 2 trainees weren't able to make one session, but both of them completed a makeup session. So I think we essentially had an attendance rate of 100%. Everyone was given 3 attempts to pass each competency domain. On the first attempt, 63% passed active listening, 100% passed empowerment-based facilitation, 63% passed goal setting, and 75% passed self-efficacy. Those who didn't pass a competency domain on the first attempt did pass on the second attempt, so we successfully graduated 8 peer leaders. And they were Laila Karim, Jatinder Sudin, Manjul Singh, Rashmi Rahaya, Balwinder Grewal, Mohinder Sidhu, John Koshi, and Omana Koshi. So the peer leaders did have the opportunity to put their skills into practice in a 6-month PLEADS pilot study. I'm not going to talk about the pilot study, but just briefly, although there were 1 or 2 health improvements associated with the intervention, our primary outcome, glycemic control, did not change in the positive direction. In fact, it changed in the negative direction, which is usually a researcher's worst nightmare. But I'm told by, I've got 2 minutes. I'm told by people, and when I say people, I mean my mother, that failure builds character, and that I'm a better person for it. So I'm inclined to believe her. But seriously, we learned a lot from our post-intervention focus groups, and some of the feedback had to do directly with the peer leaders. So apparently our participants in the PLEADS program, they didn't value as much the behavioral and emotional support. What they really wanted was informational support, and what that meant was they wanted their peer leaders to be able to answer diabetes-specific questions, like questions related to healthy eating, acute complications, long-term complications, monitoring. So those were the things that they valued the most. And ironically, we actually eliminated the diabetes education component of the peer leader training because our peer leaders told us that they didn't have the time to participate in an extensive 46-hour training program, which was the original length of our training program that we conducted with the African American and Latino community in Michigan. So clearly, this population and this community is telling us that they want their peer leaders to be equipped with a solid foundation of diabetes education knowledge. So it's back to the drawing board, and I think what we're going to do is take the results from this pilot to improve the peer leader training and also to improve the intervention. And I'd like to acknowledge and thank my research team, Jesse Dillon, my project coordinator, Gurjan Rai, Sonia Paul, and my co-investigators, Parmjit Sohal and Arun Garg. Thank you.
I just have a couple of questions, one for Scott and one for Tricia. And let's see if I can find my question for Scott. Oh yeah, I was interested in your list of experts or your panel there. And I didn't see anybody who had what you might say is health literacy expertise. At least that label wasn't used. There may very well have been somebody along those lines, and I didn't see anybody who had a label like what is it now? CDM, a CDM expert, management expert, self-management expert. So I just wondered, you probably had that on the team, but it just wasn't apparent from how you labeled people there. And maybe you could just talk about that?
Yeah, so, that's on. Yeah, so for the CDM management, most of the allied health professionals were working in chronic disease management within specialty clinics, whether it's there's one person, physiotherapist from the Pacific Lung Clinic at St. Paul's, person from renal clinic. The dietitian had spent some time working in renal clinic, cardiac rehab, as well as diabetes teaching center. So each of these individuals and the others I haven't gone into had specific chronic disease management training, also training in behavioral change as well. There wasn't, you're correct, there wasn't anybody specifically listed there in terms of a health literacy expert. So together we spent time discussing like what the questions should be on the telephone. The patients were there. We were getting their input as to how they would understand this. Is this a yes or no question, and how it might be formulated. So that's kind of the process that we went about to the wording of the questions. But yeah, you're right that we didn't have somebody specifically labeled as a health literacy expert.
Okay, well, that's good answers. And so, Patricia, or Tricia, I'd like to ask you a question as well. I thought your program was excellent, and I notice you're trying to move forward on it. And so what I thought might be missing from the program, you had a component on listening, but you didn't have a component on communicating. And I just wondered whether there might be room for some kind of a component that talks about the other side of it, speaking in clear language, and maybe even also being sensitive to literacy issues that some of the people in the program might be experiencing themselves.
Define this, but peers, again, are folks who, at least for this particular study, are the folks who live in the same community as the patients. They, for the most part, have the same background. Educational might be a little different, I'm not sure. But so in terms of communication, I think that was what we were getting at, but I think we don't have a component that really addresses health literacy, at least in terms of reading medications, and I know that actually is very important, because when we actually conduct assessments and surveys and have people complete them, they need help. So clearly that's going to be an issue that I think we want to address. So I think what I want to do is to bring on someone who is an expert in health literacy onto our team.
Sorry, I'm Linda Shohet from the Center for Literacy in Montreal. I actually, I would like to second what you said. I thought they were excellent presentations. In a way, I'm sorry that people who were here many people who were here for the first 3 days didn't get to hear these, because I think you pulled together a lot of the threads that some of us were looking for over the first 3 days, like when are we going to get to mesh this chronic disease management with the health literacy strands, and I think that's where we're going this morning. So thank you for that. And Irv asked 2 of my questions, so I don't need to ask them. But I had a couple of observations and then a couple of questions as well. One of them was that there was still a continuing strand, at least from the economic perspective, from Mohsen and Sterling, on focusing on the individual, where we spend an enormous amount of time talking about issues that relate to a triad of individual, provider, and system. And I think in terms of what you presented, Mark, you were actually talking about adjustments that had been made on the part of the provider, and interventions and accommodations that had been made on the part of the provider. There weren't really huge demands being made of the individual patient. There was much more an accommodation and a recognition of where the patient was situated and what the patient needed. And I think that has huge economic consequences, and I don't think that's being considered when all of these various models go up, and I think it's something that needs to be. So a quick example that I would like to share, and it isn't something that that we've pursued in any great detail, but in a project that I was doing with the McGill University Health Center at one point, and this is probably about 10 years ago, when we were looking at the communication that was being used for patients in breast cancer. We went into units where people were being given information, and one of the things we asked them was, what information were they giving to patients? And I would like to say that I think things have changed dramatically in the past 10 years, but not totally. At that point, when they pulled together all of the various pieces of communication, it turned out they came from all over the place. They weren't coherent, they came from different sources, and in some cases, and I know this because I did work on putting a guide together, some cases the information was even contradictory. There were some cases where a piece of a statistic that was in one was not the same that was in another. So if a patient was being given the same information or could pick it up off a wall, they could in fact be given very confusing information. But the other thing was that a lot of the information was being written in-house, and it was being written by people who weren't necessarily trained to communicate with patients, and it wasn't well written or clearly written. So there was that category. And we said, how much time is being used for this material to be developed? And there was no budget for it. It was all mainly being done by nurses. It was mainly being done on their own time or off time or evenings. And one of the things that an economist shared with me at one point is that there's something called the cost of lost opportunity, that every time a nurse is putting in his or her time doing this, they're not putting in time doing something that they probably could be doing or should be doing for their own professional development or enhancement. You're losing that. You're not getting a good outcome. But what we did was create an inventory. We said, how many hours has gone into doing this? How much is a nurse paid per hour? And we tried to calculate what the costs were for developing all these in-house pieces. It was very, very large in one department. The hospital said they had no money to put into this, but money was being expended. And the other place where money was being expended was in a lot of glossy communication, a lot of high-cost, high-end communication that was more PR than health information. And I want to ask an economic question about how we can get at some of these things and begin to address them, because I don't think the economic burden of health literacy just derives from individual lack of skill. So
It makes no sense. It's not a rational position, and I can't stand irrationality. So we want to get rid of irrational situations. So that makes sense. I mean, I've seen some patient leaflets that have been given out, and I'm sort of shocked and horrified. And so I'm sort of agreeing with you. I've seen some patient leaflets that have been given out that are absolutely stellar. And so, like, you know, it can be done well and it can be done really well. But we want to understand the cost associated with that. In terms of our perspective being the individual, you're absolutely right. I think we have had a perspective on the individual in a sense that, like, where the benefit really lies, or at least like the primary benefit from my perspective is what we're doing in terms of benefit to individual patients. So if what we're thinking about is communication from healthcare providers and how do we have interventions that can improve that, then the way that we need still to judge whether those are good, bad, or indifferent interventions is on the impact they have on the individual patient. Not, I mean, you know, I want healthcare providers to enjoy what they do, but, you know, if they don't enjoy it so much and the patient's much better off, then I think that's a better place to be.
Just a comment to give kudos to the Vancouver Coastal Health Authority. They've given Raj and I and BC Long $125,000 to develop in a culturally appropriately way with patient consumer input education across 5 different languages and different cultures. So they recognize the value of outsourcing it to more appropriate people.
I'm Nishi Dogger from the University of Leicester, where our Indian population is about coming up to 50%. So I just wanted to ask Nadia a little bit about whether it would be useful to have another variable when you're looking at cultural groups, because my concern always is that cultural group isn't actually relevant to everybody within that group, that there's huge diversity within groups. And that also tied up with Trisha's bit that, so there were 2 bits. One was about whether it would be useful to think about having the amount of time somebody's been in a country and how much of the culture, host culture, they've taken on board whilst retaining their own, because living in a family of 4 generations of people who've been in the UK differently, we all are very different in the way that we perceive healthcare and what it means to us. And I think that ties up with some of the things that Mark was talking about. So that seems to me quite an important variable. So I should have also added my back academic interest in diversity, cultural diversity, which is why I'm raising this. The other thing I wondered with your bit, Tricia, was I thought it was really, really interesting that they all seem to be a similar age and all of that. And I just wondered whether their understanding of culture and how the people, because they've got a view and where their own biases about diabetes and all of those things come into the way that they then impact on the way that they're talking to their peers, whether actually just because they're from the same cultural group doesn't mean they don't need to have some cultural diversity stuff about recognising their values, whether that would be a component that might address some of the issues that you were talking about there. You thought you were doing this, but this is what they wanted. I just wondered about those aspects, really.
Those are great questions. So in our studies, we are looking at length of stay in Canada as a kind of a proxy for acculturation, but certainly in other studies that we're doing, we're now actually surveying people using acculturation questionnaires to see what sort of degree of adaptation of the general population's culture people have taken on. Because I completely agree with you that culture is fluid, and it changes per person and it changes over time as well, which makes this type of work difficult because people often say, well, 20 years from now, everything you've done is going to be irrelevant because the world would have changed. But we do still find in all of our studies still group level differences that are undeniable. So we have, even though we do believe that culture is fluid and it does, even my cultural beliefs and the other South Asian person sitting next to me, their cultural beliefs may be different and different significantly. There are still some group dynamics that we're trying to capture. But I think that that's very relevant, that what we find in our studies and what we attribute to culture may change over time, and it may change per population and per group.
I would agree with what you're saying about acculturation, and similar to Nadia, we do ask the folks in our study how long they've lived in Canada, where they were born, where their parents were born. But you know, and even with translation, that there's so much heterogeneity in translation. The people who live in Surrey, the South Asians who live in Surrey, have some different uses of words than the folks who live in Vancouver. And so when we were translating, you know, we would have two peer leaders looking at something and saying, "Oh no, that's not right." Or we say, you know, we use the word this for ham, and it was just, you know, it was hard to really kind of take all the different the feedback people were saying and be able to come up with something that everyone would be able to recognize. So I think yeah, your point is very valid that there's a lot of heterogeneity. For our population, I think education was actually much more of a prominent factor. And when I say that, you know, like the South Asian community is, you know, it's a blanket, it's huge. And so within that blanket or the umbrella, we had Punjabi speaking Sikhs, but we also had English and Gujarati speaking Ismailis. And in terms of the way that we delivered education, it was amazing to see what feedback we got from the Ismailis. Really, you know, I come from an approach where it's empowerment-based, which means all the conversation is patient-led. So when we come into a room, we don't have a class on healthy eating, then a class on long-term complications. We have the patients say, "Okay, so what are you interested in talking about today?" "Oh, well, yesterday my blood sugar was really high in the morning, and I don't understand." And so we have a talk about how to, you know, how to fix, you know, high and low blood sugars, or if someone comes in is upset about, you know, having some strange prickly feeling on their feet, and then we talk about neuropathy. So, but for the Punjabi-speaking Sikhs, that population, that type of education where it's patient-led really didn't match well because I think, Mark, you were saying that a majority of our population didn't even graduate the 3rd grade. So they didn't know what they didn't know. They didn't know what to ask. Whereas the Somali population, they were, I think, all college educated. They already knew that there were 3 different kinds of cholesterol, and they had more advanced questions. So I think that piece is, you know, when we talk about translating an effective intervention to different communities, you have to translate even more depending on, you know, the different, you know, cultural backgrounds within what we think of one culture. So I think that's the challenge for me. And yeah, did I answer your question?
Can I just ask you what you're using to define people's cultural if we can say that, that's a word. Can I ask you what you're using in your work to define people's culture?
I tend to take a very individual approach, and I accept that it doesn't always work for the group stuff. And I think what it for me is about saying, well, we can have group strategy, but actually about saying how do you tailor it to that individual. So I think the point that Scott made, which was one size doesn't fit all, that even if everybody had internet access, there's still some people who are not going to use that. So clearly, I think we always need to be mindful that actually you've got a diversity of approaches so that people can access information or access access, whatever it is you're trying to do, that we cater for the diversity of the individual within that context. I think that's the challenge, the biggest challenge.
I agree.
One more question, but that reminds me, you all know the story of the Chevrolet Nova? No? It's a car, the Nova. And when they introduced it to Latin America, they surprisingly didn't sell any. Because nova means don't go in Spanish.
Of course. My name is Marina Nix, and I'm with the BC Health Literacy Network. Just to echo what Irv and Linda said, what a great opportunity. Thank you for bringing this panel and to bring after 3.5 days for some of us to be there and hear these presentations. And to think about health literacy as such a rich area that brings together people from different fields. So as I was, paying very close attention to all your presentations and thinking, and here Linda, who's also from the literacy field as I am, we are looking at some of the things and saying, oh, there's like, this is what we would say, coming from a particular perspective and really trying to capture that. So just to follow up the comments that Irv made about how can the approaches be enriched and look at some of those intricacies that speak about the population. So Scott, I'm just going to choose you as one of the things that you were doing when you were presenting, for example, the things that patients have to fill out, the information. And it looked like it really required a very high level of literacy, even though maybe the same things could be asked with much plain language, and how much that confuses the data that you collect. In terms of who's filling it out. I would be very interested in knowing the level of education, for example, or the access to other sources that they have. So this is almost a call, I'm going to speak about that later today, but a call to really bring into the teams and to bring the expertise of people from other fields.
Yeah, and I'll preface by saying that we developed this before I was ever even interacting with people from health literacy and stuff like that as well. So it's a learning experience for me. And so I agree that, and especially probably when I was looking at slides, I said, oh my goodness, when I show the action plan, people are going to like, so I'm glad that you spared me that question. So we have done, for some of the questions, we developed them through heart failure. We did a pilot study there and got some feedback from patients through interviews and then modified them, because we at first had the same question compared to yesterday, are you feeling short of breath? And then they would answer like 1 to 5 right away. And so in our interviews, the patients wanted it to be a yes or no type of question. And then when went to yes, then we flashed up the 5-point Likert scale. And the question that I don't have the answer to is how people are interpreting those questions. And so that is something that we could do with our exit interviews or maybe ongoing. So at present, I could see that also even when I'm talking to my friends that, we get caught up in our jargon. Oh, well, of course I know what short of breath means. And even in heart failure is probably one of the challenging ones, because sometimes the care providers dance around the issue of heart failure because it's very dramatic to hear that you have heart failure, because people take it literally. I concur that we could make some improvements. The one kind of saving grace for our end, whether purposely or not, is that internet access also tracks with education, so that people who have internet access are probably going to be more educated and more understanding. And again, we also get into, when we do these studies, regardless of literacy or not, there's always this healthy volunteer bias. We're not getting people who don't want to do these things. And when it's a randomized study, the bias is always, nobody wants to go in a randomized trial to be in the usual care. They can do that at home. They don't have to fill out forms to do that. So some of the things still where I would still say that in our studies we're getting the kind of the cream of whatever the crop is, but we need to figure out. And one thing I was thinking of is maybe our invitation letters probably. Yes, and maybe those need to be looked at more acutely.
Okay. Sure.
Yes. Yeah, and these are all like highly, yeah, one of the guys does, fortunate for us testing, unfortunate for him, he had all 5 of those conditions. So he really gave the model of care run for its money. But these are also people that part of a volunteer organization who want to give back as well.
All right. Well, by my calculations, we started 7 minutes late, and we're now 4 minutes late. So I made up 3 minutes in time. And let me just use a little bit of that to, again, tell you from my opinion as an outsider how lucky you are to have an organization like the Peter Wall Institute sponsor these sorts of events. It's quite unique, and I'm looking forward to what you decide to do as a next step.
Yeah, 5 o'clock this afternoon, you have the plan.
I'm at 5 o'clock. And it's a good thing I don't have to get on a plane until 5 a.m. in the morning. So thank the speakers, thank yourselves. We're now have a coffee break.
Good morning, and thank you for having me here. I'm going to be reporting on some initial work that was conducted by Ebony Rempel, myself, Dr. Jerry White, and Dr. Anita Catheri, looking at First Nations young adults' health literacy skills. And I'm going to start with a little bit of an introduction and some points that we took from the research literature that really informed and directed our research. And that is, looking at the 2001 Canadian census, we recognize that there's over 1 million First Nations, Inuit, and Métis people living in Canada, and about half of this population is under the age of 25 years of age. We also know, and there's substantive literature and research that suggests that First Nations people have significantly poorer health status than the rest of Canadians. And this is particularly the case for chronic disease. So we're recognizing that there's an increased prevalence in chronic disease, certainly within the Aboriginal population, but I think across North America as well. And it's with this increase in chronic disease that we've identified really a shift in the care paradigm from one that's been more of a curative care paradigm to one that's more a management paradigm. And with that comes the expectation that clients or consumers are going to self-manage, self-health promote. And again, aligned with that is then the need for current, relevant, and accurate information. Along the same line, and I think it was Scott that talked about it, the increased use of the internet across all age categories, but I think particularly among the younger cohort of individuals. And so there's almost an expectation that we are going to be online information seekers. So what that said to us in kind of the entirety was that there's a need and an increasing need for health and e-health literacy skills. Again, from the literature, we know that generally as Canadians, we have poor literacy skills and health literacy skills. But what we don't have a lot of research on is the literacy, the health literacy and the e-health literacy skills of First Nations people or Aboriginals. So in our research, we chose to define health literacy as this ability to access, understand, evaluate, and communicate information. But we also informed our research by NutBeam's framework of health literacy, that being functional, interactive, and critical health literacy. And to ask the question or to explore the health literacy skills of First Nation young adults, but we looked at individuals and we wanted to look at individuals who are living on reserve. And so our question specifically was, what are the health information needs and information access preferences of First Nation young adults living within on-reserve communities? So because this is a new study in a new area for us, we used a very exploratory design, that being qualitative descriptive, and we incorporated some principles of community-based research as well. We looked at a single, or worked within a single First Nations community within Ontario, and our participant recruitment was supported by a local, so on-reserve community health clinic. We used convenient sampling as our sampling strategy, and participants were included in the research if they self-identified as being First Nation, if they ranged in age from 18 to 34 years, and if they were agreeable to participating in a discussion about their information needs. So all of the data, all of the conversations or interviews were conducted within the health clinic that was on the reserve. The conversations or the interviews lasted about 60 minutes, and we asked individuals about their traditional health and healing practices, how they might see their heritage influencing healthcare practices, looking at health information needs, preferred sources, and how they use the internet and social media particularly. In terms of our analysis, we looked at use an iterative process, codes into themes, and multiple people looked at the data. We had 8 participants. All of them were young adult females, all young mothers, and all of them came from one on-reserve community. The mean age of this group was 23 years, and that I believe ranged from 19 to 25 or 26. Half of the young women had a high school diploma. I believe one had a college diploma and the rest had elementary and then some high school. Their mean income per annum was almost $13,000, ranging from $6,000 to over $21,000. All of them indicated that they had computer and internet access, and all of them had a smartphone, either an iPhone or a BlackBerry product, which is really the only choice that, no, maybe not, there's more choices. So what emerged from our data were 3 broad themes, that being traditional health and healing, health information needs, access to health information, e-health literacy. You can see we weren't being that creative and innovative with our thematic names, but then some additional sub-themes that aligned with those main themes. So I'm going to take you through some of those. And I'm going to let the participants do a lot of the speaking from here on in. So we were challenged with some of our assumptions around traditional health and healing. The participants, all of them, indicated to us that this wasn't an issue for them. So participant 8 stated, well, no, not really. Like, there's no special ways. I just do the normal stuff. See my doctor, get checkups for my kid, get the flu shot, that kind of stuff. And participant 2 also iterated this in stating, I haven't really gotten into anything like that, so I don't have any details or background of anything like that, and they don't offer too much or too many of those things here. And they were referring to the clinic with that's situated on their reserve or within their reserve community. That didn't preclude them, though, from wanting to know more. And so this was really nicely put by participant 1, and she states, I think my heritage is important because so much is lost. It would be totally worthwhile if we were going to have any kind of practice or traditional medicines here. And I really appreciated participant number 3 because she stated that she really wanted information about traditional health and healing practices, but in a very genuine and authentic way. And she states, there should be more of it. Maybe they could bring in some older traditional ways of healing and stuff like that. It would be neat to see, instead of just a doctor in a room with dream catchers. So I loved her. Some of their priority information needs were about their children. And that was at the expense of some fairly significant health issues that they were dealing with themselves. So they were attending the clinic for mental health issues and for different issues, counseling and support, treatment for substance use. But all of them stated that it was about their child health care needs, and participant 7 really speaks to this nicely in terms of since she's been a mother, her number 1 priority is looking after her son. In terms of access to health information, I think this supports some of what we've already heard from speakers today. Their preferred information source was their doctor. And when their doctor wasn't available, it was off hours, they would call telehealth. And in Ontario, telehealth is manned 24 hours a day and with registered nurse support. So they were looking for that expert support. And so that was very clear to us. Who else was very important for these young women were female, family, and friends. And so this wasn't a surprise to us. This is typical in terms of information access in kind of the research that I do. So participant 7 really summarized it nicely, that she asked her mom about something that's going on with her son. She has kids, and so I would connect with her. What was quite interesting, and I think, again, challenged some of our assumptions with this particular age cohort, was their computer skills and navigation. And so some of the young women felt very challenged just in terms of manipulating the technology, the computer itself. And so participant 1 states, I would always go straight to the doctors. I don't think I would ever go to the computer because, like I say, I don't really understand how a computer works, let alone how I would go about asking certain questions. And this became even more clear in terms of their online seeking and decision-making around what's important information and what isn't important information. And so participant 4 stated, yeah, I'd go to Google, I'd type it in, and you know how that whole big list comes up. And she said, I just click on one that looks the most interesting and has the most information. Whether or not that's good information, she didn't feel comfortable in discerning that. So participant 7 said, I would like to use the internet more and things, but I would want someone to teach me more about how to use it. And so very clearly, they know that the information is available. They're just not sure how to get a hold of what would be considered the best stuff. All of the young women access social media, and so they did use Facebook. And so participant 3 said, I would post a few questions there because there's other mums that also know some things. And so they would connect on Facebook with their female family and friends, but they would also, a few of them talked about going to parenting groups or parenting chat groups online and through social media, particularly Facebook. So I've combined kind of the discussion and the conclusions, and I'm very interested in some of your thoughts around these findings. In terms of the lack of traditional health and healing, we're quite suspect that perhaps the legacy of colonialism, residential schools, may have had an impact or an influence on this lack of traditional health and healing practices within this cohort. And I will remind you again that it was 8 participants, so it's within this very confined and focused, unique group. We were and were not surprised by their focus on child health information needs and services. We recognize that that's a very high or intense information time. So as children are developing, information changes as children change, and lots of things are going on at early childhood development. And so that wasn't so much a surprise for us. What was surprising is that they had quite substantive health issues and really negated those health issues in terms of at the exclusion of looking for child health information. Again, that they sought out experts is fairly consistent with what's in the literature with respect to individuals with low health literacy or limited health literacy, in that they don't feel that they have the expertise to, in a really significant way, contribute to conversations around health and around decision making, and would forfeit that to the expert. And so they really did want to talk to healthcare professionals, but again, within the Aboriginal First Nation population, there is a strong matriarchal aspect of the culture, and so female family and friends weren't inappropriate. What we did really get a good sense of was their perceived lack of confidence in discerning or determining what was trustworthy and credible information, particularly from an online source. So from this very beginning research, we just think there's so many opportunities to continue to explore the issues of health literacy within Native populations. And so we're very curious about finding out more about their awareness of and how to integrate traditional health and healing practices within community clinic. And some of our conversation over the last few days has been about participatory research practices, and this would be a really important participatory research project to begin to implement or integrate, figure out how to, some of these practices within this cohort. We'd also like to put more effort into exploring the personal health information needs of young adult women, but also of men. We didn't have any male participants. And we're very interested in if there's differences with individuals that live off reserve versus individuals that live on reserve. And certainly further exploring smartphones and online health information use and access. It was quite fascinating when we asked about using the internet. A lot of them said, no, we don't use the internet, but all of them had a smartphone and were connected to Facebook. So they didn't kind of conceptually link the fact that the internet is also on their smartphone. That is just, a conversation or a discussion avenue. So it was really interesting for us conceptually how they separated those two things. So I think I'm within my time. Love to have conversation and questions about this at some point.
Thank you.
Okay. So just briefly, I do have a CRC chair in early literacy, but I made it very clear when I accepted that position that I don't see early literacy as separate from child literacy, adult literacy, family literacy, and so on. That literacy, I see it as a cycle. I'll show you some of that in a minute. So my purpose in my 15 minutes here today is to convince you that literacy does not exist apart from literacy and practice, that literacy is only literacy and practice. And when I was thinking about how we can think about that, I mean, I'll give you some examples of how we've applied that notion, but in fact, I decided I wanted to tell you a story about my son when he was very young. He's 36 now or something, but he was 5 years old, he was going to kindergarten, and there was a carpool thing going on. So it was my turn to drive, and that day they had started to learn about how to tell time. And so in the car on the way home, he had his little clock that they had made. It was an art school. So a little clock with a little hands on it that move. And I hear, this is in Oakland, California, I'm just fighting my way through traffic, and he's way in the back, and I hear this voice, "Mom," and I said, "What?" And he said, "Are all living things in time?" Yeah, they are. And in a way, that's the way that I'd like to convince people to start thinking about when you use the term literacy, when you think about measuring literacy, you even conceptualize what is it to be literate or not literate, you are talking about literacy in practice. And the reason I'm emphasizing that right now, because it sort of sounds common sense, is that, for example, I've worked with health literacy since the IOM report a while ago. And so health literacy is a field that brings together the notion of literacy and the notion of health. And so when I was asked to present at this conference, I was asked to talk about how is literacy like health literacy? Or how is literacy different from health literacy? That type of thing, where you're still conceiving of these two constructs, literacy and health, as separate, that can be joined. What I'm saying is that literacy is never separate from health literacy, from financial literacy, from relaxing at night with your mystery book literacy, with grocery store literacy, so on. So we're simply talking in health literacy, from my perspective, about a type of literacy, okay? And that you can't pull literacy out. And I suspect that a lot of people think of literacy maybe as some sort of notion of it's the beginning skills, or it's the skills that then make you literate, and so on. So I'm just going to show you how, using this way of looking at literacy as literacy practice, where do the skills fit in, and how do the practices that affect those skills. So you see up here, literacy, and we know this isn't just dreamt up our favorite theory. We know this through a lot of data. Literacy is always socially situated. It doesn't exist anywhere else, even if it's in school. If it's in school, it's school literacy. It has its own purposes, it has its own social functions, it's surrounded by power relationships, and so on. Literacy is language. So literacy is a community practice, and it's making meaning. The literacy I focus on is print literacy, so you'll see most of my examples from that, but it also applies to oral literacy. And it is a way of making meaning of something, okay? So that's where it puts it into a social context. So here I'll just give you some examples. We'll go through fast. So here's somebody who is reading a newspaper, and what's he doing? Is he reading for information? Partly. Is he reading to wait for his airplane? This was taken in the airport. Yes. And why is he in that airport? What are the constraints on his literacy in that airport? And so on, like that. Here's someone who is using literacy as part of her work life. She's bringing her numeracy skills, her reading and writing skills to it, but those skills are shaped by the demands of that task, which is situated within her work. Here's somebody who is truly wasting time, he told me. And he said, please don't, you can take my picture, but don't show it to my boss. So he works in a kiosk in a mall, and he is just sort of flipping through the newspaper, just hoping somebody will come up to try to buy something. This person is totally engrossed in a novel, and she's clearly trying to also sell something, but she brought something to read along the way. That's the social context. Looks where she's sitting, what is the lighting, what are the demands, how does she know when somebody's going to come up and talk to her, and so on. These people are sitting outside of a mall, and they're filling out application forms for employment. So you can just think about whenever you've filled out a form for a job, how does that drive what you say, what words you use, how you put them, and so on, like that. Also, the demands of reading that form and trying to understand what is it they're looking for, what is it they want, how much room have they given me, and so on. So as I said before, and I'm going to now call the literacy that my work is focused on print literacy to distinguish it from the rest of the big picture of literacy, okay, so reading and writing. So actually literacy, from my perspective, starts before kids begin school. You start to learn to read and write before you start school. How do you do that? Because you are immersed in a social context where there's print all around, and we have studies from all over the world, and we can actually find print available in almost every place in the world. And you see people using it. It's not just the presence of print, it's the use of print that children see and they understand, they start to figure it out. So with this population, highly educated people in a print-intensive world, young children as young as 3, maybe even 2, might say, what does that sign say? It says stop. What is it, oh, so that's why we stop our car. They might be able to recognize their cereal boxes in the store and so on like that, because they've seen people use it. We have data on children growing up in totally non-literate homes in the United States who, although they're surrounded by print, because it's a highly literate country, they've never really seemed important people to them read and write because they can't. And so they don't even know to look at print. They think print is like a decoration on the wall or on the street and so on. When you get to school, we have data, I'll show you some of that later, that shows that the cognitive skills, the decoding, the vocabulary, the comprehension, the fluency, and so on, that you learn in school, and much of that needs direct instruction in that. But we've shown that children who engage in school in real life reading and writing activities, in other words, socially situated activities, like we're going to put on a play, let's invite our parents, let's write an invitation, we'll mail the invitation, the parents come, on all the literacy that goes into all of that. The more children take part in those types of activities in school, the higher their skill levels show on decontextualized skills tests compared to those who don't. Then once you learn to read in school, you get out, it's actually during school, but say you graduate at some level, you get out, you have a job, you are now not learning to read and write anymore. You are reading and writing for many, many different social purposes. And many of us then go on to have children who then grow up in our homes, watch us using print, enter school, and so on. So in a way, when you think about learning to read, or sometimes people think about the basic skills as, as very school-based, which in a way they are, if you're going to deal with them as very isolated skills. So most of our kids this is cultural, but in the Western model of instruction, the process, even though you have different favorite methods from different time, is basically the same in terms of the literacy instruction. But depending on how your students go on to use that, okay, actually that comes from the settings they're in at the time, what cultures they are in, what work cultures, what social cultures, what religious cultures, and so on like that, their literacy practices will look different. And they will be shaping those literacy skills they've learned in different ways. So you see this is an attempt to show that literacy becomes literacies when you start using the skills that you've learned. You no longer can talk about one literacy, it's literacies. And that's why we talk about health. We still use the term literacy, and it is a literacy, and there are other literacies. So if you're literate, you command, depending on your life, different literacies. So, again, print literacy ends in this socio-cultural practice of literacy, and health literacy is actually one of those. Literacies are fluid, so they change over time. Why do they change? They change because of life circumstances. So this comes from a very large study we did in the United States across all of mainland US in a randomly selected, 79, I think, different adult literacy classes across the United States. And this was from our qualitative analysis. And we found out that people reported changing their literacies, and they reported that change within a context of telling us about their life changes. So, for example, I learned how to read forms when I had to get a job. My husband died, I had to get a job, and so I applied, and they gave me a form to fill out. So I had to learn how to do that in order to get a job. If they go back to school, which all of these people had done, of course, they say, I didn't used to read poetry, okay, but now that I'm in school, I read poetry or I write in a journal more. Some of those practices drop out when they leave the school because they don't need them or don't want to use them, but others they hang on to because they were new, they learned them, and they like them. So one lady reads poetry now more, and so on. Also, another thing is moving. So especially older children, young adults who move out on their own, suddenly they have to learn how to look at leases and understand them. They have to know how to look for a place to live. They have to learn how to read those ads for renting an apartment and so on. And those are not easy to read. And you have to learn all those little abbreviations and so on. When they have children, they suddenly are thrown into a lot of health literacy, for example, development, child development, and so on. New relationships, and so on like this. So we've actually devised this model of a literacy practice, and I'm not going to go through it all, but it shows how the actual literacy event is in the dark gray, how those are contextualized by social purpose, social activity, power relationships, values, beliefs, and so on. And these are the different domains that we've identified through all these case studies of literacy practice. These are just some of them. There's art, civic, participating in civic life, participating in community life, participating in clubs and opportunities, entertainment. Eating was a big one, and then we have our definitions and then the types of things people read and write. I have copies of my overheads that people can pick up later. Health literacy is on that list, and this is how we've defined it for our study. It's a domain of social activity centered around the maintenance of health, physical fitness, and bodily care. And there's some of the texts that people read, the kind of literacy events. Reading prescriptions or shampoo bottles, filling in a medical form. These all came from our data. So that's my point, is how literacy is an instance of literacy. I want to hurry on. So I'm going through this. Here's just so I can participate in the in the culture of graphs and numbers. So we did this large adult literacy study and looked at the changes in the literacy practices of the students depending on how many real-life reading and writing activities they took part in as part of their instruction. And so it goes, we call that highly authentic. So you see that the highly authentic line is the thicker line, it's higher. The somewhat authentic is maybe real text, but not for real reasons. And the somewhat school only it's mostly reading to learn. With little children, we did the same thing in the science class, and you can sort of see how the more they take part in those activities, the more they learn, and so on like that. And my last slide is that with this definition of literacy, we talked about measurement a lot in this panel, validity issues are huge. And just because they're huge, though, I don't think we dare ignore this complexity, because then we get into the situation of teaching people to do better on tests to show our intervention works rather than actually measuring a real change. So I'm out of time, so I'm just going to stop. Thank you.
I am a physiotherapist, and I'm a health services researcher. Since I was a trainee about 25 years ago, and you can do the math, it's really exciting to see that we went from the point that trying to help patients to manage what is supposed to be inevitable damage in the joint, poor health, and poor quality of life for the rest of the time, to the fact that we are now aiming to get to the point of remission and a normal life with better treatment. But one of the things that we also know is that with the advances of the treatment, it's only beneficial for those who can get it, and more importantly, get it early. So what I'd like to do in the next 15 minutes or so is to talk a little bit about the disparity in care, focusing on arthritis, and then share with you a project that is ongoing, that we're developing a decision aid to help people to make good treatment decisions. I think my larger research program focused on self-management, and I think part of being able to self-manage effectively and efficiently is that people need to have the skills, the knowledge, and the ability to be able to make treatment decisions along the disease continuum. 1 in 6 people in Canada have arthritis, looking at the ones who are over the age of 15. And I think some of the speakers earlier have talked about the fact that in chronic disease, arthritis no exception, the prevalence and the severity are higher in some population groups. We know women tend to have a higher prevalence of arthritis and more severe condition. First Nation population, we heard about that, and some estimates says about 19%, but we think that is actually a little bit low because some of these estimates actually come from a largely off-reserve population. And we also know that people with lower socioeconomic status groups tend to have higher prevalence and more severe condition. Some types, well, there are more than 100 different types of arthritis, let me just put it out there. And some types of arthritis are actually risk factors of heart and lung disease, and I think that's pretty much my connection with the heart and lung research colleagues. Using rheumatoid arthritis as an example, which affects 1 in 100, cardiovascular disease actually is the leading cause of premature death in people with rheumatoid arthritis. And there's been quite a bit of data showing that it is actually responsible for a reduction of life expectancy for up to 5 to 10 years if people are not treated properly. Colleagues from the Arthritis Research Center recently published a systematic review looking at cardiovascular disease mortality in people with rheumatoid arthritis and found that people with arthritis have their risk of dying from cardiovascular disease up to 50% higher, with women more affected than men. Now, the good news is that we know if people are able to access appropriate medication early and persistently, their risk of dying of heart disease actually can be lower to the level close to the general population. But the fact is they need to be able to get it. Now, they're effective treatment, but when we look at research studies, oftentimes the information around effectiveness is what we see in the sample or the population that we're doing the study. But once the treatment is brought to the community, oftentimes you see that in subgroup of populations will benefit more than others. And it's nothing to do with the disease activity, disease status, but it has everything to do with their personal characteristics or perhaps their socioeconomic status. So to think about the different factors that may have an impact on health and access to health care, some of the work that was done in injury prevention and mental health has developed this framework called the Progress and eventually extended as the Progress Plus. And this is the framework that organizes factors across which if you observe differences in treatment effectiveness, you can then pretty much consider that inequity actually exists that causes differences. So for example, the place of residence, where people live can make a difference in terms of how they benefit or not benefit from a treatment because of access issues. Their race, their occupation, gender, religion, education, socioeconomic status, and access to social capital and networks around them. The Progress model eventually extended to the plus components, which also include age, disability, and sexual orientation. Now, health literacy traditionally has been grouped under education, but there has been a lot of discussion in people working in health inequity, suggesting that perhaps health literacy should move over to the plus side because of its unique contribution to health, to access to care, and overall well-being of individuals. So let's come back and talk a little bit about disparity in care in rheumatoid arthritis in particular. So we know that in people with RA, disease-modifying drug, or what we call DMARD, if used early and persistently, so early and persistent, can help to prevent joint damage and also to reduce the risk of the premature death. But we also know that across Canada, excellent data from BC, Ontario, and Quebec showing that only half of the people with rheumatoid arthritis actually will get DMARDs within the first year after their diagnosis, which we all think that is really unacceptable. Now, for people who try DMARD, a recent systematic review actually showed that up to 70% of them actually do not adhere to their medication. So they may stop once they start to get better, or they start playing with the dosage without telling their doctors, which again, these are some of the people that we eventually see in the clinics having a flare-up because they don't follow their medication prescription. Now, a few of us did further research to understand a bit better why people are not taking medication. So Deanne Lacaille, who is a rheumatologist, did a survey of patients with rheumatoid arthritis who choose not to take the medications. And, and what she found, the top 5 reasons, which are not surprising actually, people said that they were not told by their doctor. They didn't think that they needed. They were afraid of the side effect. Some people don't take medication because they just prefer to avoid it altogether. But the last point that in Deanne's study that I think is really alarming is that about 20% of the people she surveyed didn't know that DMARD actually can help to prevent joint damage, which is the number one most important information that need to get across to patients why they need to take the medication. So we subsequently got a CIHR grant and to study a bit more about what were the process that people went through when they were making decisions about medications. And we specifically interviewed people who were recently diagnosed within the past 12 months with rheumatoid arthritis. Overwhelmingly, people were telling us this feeling of uncertainty, the sense of ambivalence about when it comes to making medication decisions. On the one hand, they talk about their concerns about the consequences of the disease. So it's not that they didn't know that they need the medication. They worry about what's going to happen if they don't take the medication. But on the other hand, they were also very concerned about what happened with the side effect. So they constantly talk about this darn if you do, darn if you don't, sort of a feeling. At the end, we interviewed 38 people in this study. The vast majority of them actually took the medication at the beginning, but later on, when they start to get better, they start reducing the dosage, they change the frequency they take it, and most of them didn't go back to talk to their doctor about it. So what we thought was that, if this uncertainty, this sense of ambivalence actually may have contributed to why people not take medication or not adhering to their medical treatment. Perhaps one thing we need to do is to use better way to convey information for people when people are making decisions at the beginning when they're making with the medication. So we subsequently got funding and developed a web-based decision aid called the Answer. It's an acronym of something, but it's not important anymore, so we just call it Answer. So our goal at the time was that we wanted to help people with rheumatoid arthritis to make informed decisions about using a drug called methotrexate, which is the most common and effective DMARD for rheumatoid arthritis. The approach we took was that we apply a concept called edutainment, which we borrow from another group from Houston, Texas, that developed a decision aid for women undergoing cancer treatment and trying to make a decision which way to go. So the concept, simply put, was to use an entertaining format to convey educational information. So there are methods, algorithms that you can use to develop this information module that is engaging, fun, and entertaining. So what we did with Answer was that we present the same information in 3 different ways. Some people like to read, some people like to listen to the information and they don't like to read, and others like to have the information put in context for them. So we have all 3. Plain language text, we have voice recording for all the things in text, and we also develop animated stories using Adobe Photoshop, the cheapest way that we can do that. When we first took this idea actually to the software industry and say that we just want to develop a tool that will benefit patients, and the reply we got was that we have $500,000. So that's why we use a different way to do that. Just to give you an example of what we did. So the animated stories that we've created, we're not Hollywood. We cannot, do the Pixar, sort of work. But what we did was that we took a series of pictures with real person. We used the Photoshop to take away the details on the top right. Bottom left, we took away the color, and then we slowly layer them back in the way that we wanted. And in that process, we can add details, we can strip away some of the characteristics of the individuals, and then we sequence those photos together to give it the animation. So in the Answer, we use the decision that we want to help people to make is that whether to start the treatment now or to refuse methotrexate and talk to their doctors about other treatment options. And we feature 6 different patient stories. People will enter the website, they get the introduction, use the animated story, and then after they finish, they can set up an account to go through a set of what we call the value clarification question, basically to help them think through the pros and cons of each one of the options. They fill out some health status measure, then they're told what to do when they exit. And at the end, what happened is that we produce a 1-page summary that summarizes their initial preference, their questions, and the health status measure, which they can email to their doctor or take to their doctor at the next visit so they can discuss their treatment option. We did a very quick study. I'm just going to show you a very quick result that we did in a proof of concept study. 30 people, about 55 years of age, first diagnosed, and they're methotrexate naive. After they used the decision aid, we found that they were able to make better decisions and not feeling as conflicted when they were making a decision, and their knowledge also improved. However, the effective consumer attribute, which would take a little bit longer to develop, obviously did not change at the time. We also found that about 2/3 of them were able to make a decision one way or another, which is actually quite consistent with some of the other studies on decision aid. I have 2 more slides and I'm done. The Answer is available on the Arthritis Society website for free access. Right now, we're doing another study that are actually developing a 2nd level of decision aid for people making decisions around biologics. So bottom line, I think digital media give us really innovative ways to be able to present information so that people can get it when and where is needed. And I think investing in consumer-based research is absolutely important, and we certainly benefit from it. So, thank you.
It's so great to be here, and what a responsibility also to be the last speaker, at least for this series of presentations. I'm shorter. If I had to draw a diagram of what has happened in the last 3.5 days, I would have people coming with a bubble about how they see their practice, how they see the theory, the research, and everyone has a different design, right? And I would do either colors or do dots, and others would have lines. And then we're trying to communicate and tell them, this is how I see the world, and the other one comes down the other way, and this is how I see the world. And sometimes we really cannot put those dots and arrows together, and sometimes we can, and we can have, interesting, we can have all kinds of metaphors about colors and things like that. And I'm thinking about this morning, and Victoria saying, I'm going to try to be part of this culture. And what we're having, I think, when we're talking about health literacy is the bringing together people working in different fields and sectors and trying to communicate. And this is how the reality looks to me, and this is how it looks to me. And how are we communicate? How are we going to bring that together? That's an interesting challenge. I think it's particular for health literacy because the people coming together are sometimes bringing very different worldviews and ways of practicing and different values as well. So what does that have to do with what I'm going to tell you about? I'm not going to talk to you about a project or a particular research project. I'm going to tell you the story of the Health Literacy Network in BC. And why I think it's interesting is, well, for many reasons, but for this group, I think, because there's an interest in creating a hub. And there's some stories that, some things that we have learned as we worked with the BC Health Literacy Network that might be of use. And because we haven't been particularly successful in engaging doctors and people in the medical field, and maybe this is a good pitch and we can get you on board and see if we can connect. We also have been talking about how do we make health literacy a priority? How do we convince people to buy into it or put funding into it? And we've talked about it from a policy level, making the economic argument. I'm going to tell you how we are approaching it from a grounds up approach, and we're doing some things. Many things can be done without funding, not everything, of course, and many things you cannot do without funding, but other things you can do without funding. So I'm gonna tell you a bit. So this is what I want to tell you about. I'm gonna do a quick overview of how we came together and the development, how we are organized, the work that we're doing, some challenges and achievements, and where we're going. And maybe that will convince you to join us. So interestingly, we started with, in 2008, the Center for Literacy in Montreal that Linda is the executive director for, organized a health literacy institute in Calgary. It ended up being such a good institute, and interestingly enough, it was focusing on developing curriculum for health practitioners. But after that meeting, a few of us came back to Vancouver and we said, we started talking when we were still in Calgary, saying we're in a great position to do something in BC. BC was like the perfect storm was forming. So we started working together and got a group of about 8 or 9 people with from different sectors talking about what can we do? How do we move this conversation forward? And you see the institute was in October 2008. In March 2009, we put together a roundtable. March is a good month because budgets close and everyone has to spend the money. So we were rushing to get that money spent. Yes, give the money to us. So it was cheaply done. Well, cheaply done is probably not a good way of the word cheap. Maybe my ESL comes through. But we were able to do it. We were able to do it with low cost. Good, thank you. Low cost, and got piecemeal funding, I would say, because we got a bit of money here, $2,000 from this group, and another one could put $3,000. The Ministry of Health couldn't fund it unless they funded food. Okay, sure, yeah, give us the money for food. So we put that money together and got the first provincial roundtable with people. We were able to get people from very different sectors. I was on the phone trying to get someone from the Ministry of Education and at the directorate level. And she said, do you think I should go? I don't know if I should go. I said, I think that you should come. And she came. And after the first, even before we had the first presentation, she came to me and she said, thank you, Marina, because just by having come here, I already was able to talk to someone from the Ministry of Health that I would have never been able to do had I not been here. So just getting people, and this was another director, just hello, yeah, what can you do? What can we do? Very, very interesting, just bringing the people together. So for that first roundtable, we started talking about what can we do, and we worked together. We thought that collaboratively we were going to articulate a BC health literacy strategy. What would it look like if we wanted to move on health literacy? What would be the steps and what would we want to do? So we had the roundtable, we had ideas, a group of about 10, 12 people, again from different sectors. We went away, we worked and met and produced different drafts and exchanged ideas. And then we called a second roundtable in 2010 where we discussed the strategy that we had put together. Interesting, and I have I wonder. So that's the report from the first roundtable. And this is the second roundtable, and this is doing it. Okay, no, okay. So, and we have the strategy that we brought back to the same people who came to the first roundtable and invited more people there to discuss it. Very interestingly, that for this second roundtable, we were able to get funding from the private sector, which in itself, at least in the area of education, we are not very used to getting funding from Pfizer or pharmaceutical groups or whatever, and raised all kinds of issues. Do we want them here? Will they use that? What do we give them? Do we give them space and time? And all interesting questions, again, cultural from a sector perspective. So we had the second roundtable, we agreed on that strategy and then looked at, so how do we move it? How do we move that strategy? And we developed a structure and got people selected for a steering committee. Again, with a lot of process involved, we were very clear that we wanted a good process. This had to be collaborative. We have, in the strategy itself, we talk about how are we going to work together. So we described who should be in the steering committee, what kinds of groups we want to represent it. We are very aware that we bring health and literacy and other sectors that have very unequal powers. When we're talking about power, not only patient provider, but in this case, the health field is much better funded than the education field, and we did that the literacy field. So we wanted to make sure that the communication was very respectful. And in 2011, we called for the advisory committee, and we established it. And then we had a basic website at the Douglas College, and we moved it to the Public Health Agency of BC, held a summer school on health literacy, sponsored also by the Public Health Agency of BC. We had different workshops that we partnered with other groups to do, and presentations, and we had face-to-face meetings. In 2012, we started thinking, okay, this thing, we're not moving enough. How do we really get the strategy moving? And we decided to organize 3 working groups based on the strategy that we had defined. And each working group is focusing on a different audience. One is the general public, the other one is health providers, and the other one is other partners. So other organizations that also work in health but are not necessarily defined as the health field. For example, AMSA, which is the Affiliation of Multicultural Societies that works with immigrant populations. So that would be a partner organization that we would need to engage because they are the ones who really receive the new immigrants. And right now we're working with, that's the website. And I'm putting it up there and I can direct you to it, but I'm reluctant because it's not very updated. And that's one of the challenges that I'll speak to. How are we organized? So we think of ourselves as a network of networks. So you see there's 2 networks there that are specifically health literacy. One is the Mental Health and Substance Use Health Literacy Network, and that's sponsored by the Provincial Health Service Authority Mental Health and Substance Use Group. And they themselves their focus is mental health and substance use. But we are organized, and they have a representative in our steering committee. And then there's a Public Libraries and Health Literacy Network, which I coordinate, that looks at the role that public libraries have in helping individuals access, communicate, and evaluate health information. And then we have other networks that are also working. Maybe health literacy is not their main focus, but they also have a role to play. So we have the literacy outreach coordinators that are that are in every community, and they are coordinated by Dakota. We have COSCO with BC, which is a network of seniors. We have the Patients as Partners that's sponsored by the Ministry of Health. We have AMSA that I just referred to with immigrant populations. And we have Réseau Santé, who works with the French-speaking population in BC. So what we are doing is we are having regular meetings. As I said, we have the 3 working groups, each setting out an agenda. Interestingly enough, the health professionals and the partners working group are the 2 that have the most defined action plans right now. The general public one is struggling to get to that. And we are partnering with PHABC on summer schools. Challenges. Access funding, and the funding can keep the momentum, it can keep the focus. And right now many of us are doing it off the side of our desks. It's just, we believe in this, we want to do it. Oh, okay, yes, okay. So that's definitely a challenge. Reaching certain sectors, it also has been a challenge, and keeping that momentum going. People want to, so what? What are we doing? We're talking. What are the plans? And here's where some of the things, without actual funding, are difficult to move. Ideally, we would like to have funding to have a coordinator for the province, even a part-time we had discussed. But some achievements. Network approach. We are working and creating support. So if someone wants to receive information about health literacy, they typically contact one of us and we can direct them and get that going. Cross-sectoral approach, we have government, we have NGOs, we have academia, practitioners working together and talking about that. But we also have, and that's something unique to Canada, I think, but in BC, we've been very good at bringing the literacy and the health field together and other service fields. We have maintained conversations, initiated, we've learned a lot from each other, and we developed and contributed to influential projects. Connie Davis presented on this project yesterday. Although this was not a network project, it was definitely, some of us were involved and we exchanged ideas about that. And we also worked closely with the group that developed this document, which is a Canadian approach. So what are we going to do? We continue sharing our work. We review working group plans and choose our priorities, hopefully access some funding, be prepared. Like someone said yesterday, Lori was saying, be ready because when the window opens, we want to be there with some projects. And a call for anyone who's interested, policymakers, practitioners, students, and researchers are welcome to participate. You can contact Leona Gadsby. Leona, do you want to wave? Leona, who's with Dakota, the literacy organization in BC, Herb Rudman, who you know, or myself, and there are the email, and that's it. Wow. So.
Just a short correction. Marina did a great job of presenting our network, but misidentified PHABC as a public health agency of BC. There is no public health. It's actually the Public Health Association of British Columbia. And the other thing about the Public Health Association is that the steering committee appointed us, asked us if we would act as a coordinating organization for the network, which we're doing.
Thank you very much. Questions?
Great. Those were excellent presentations, and I learned a lot. I actually wanted to ask you a question about your First Nations work. We'd done a study looking at smoking cessation for on-reserve First Nations patients, and overwhelmingly they did not want nicotine replacement therapies, and they want to do something lifestyle. And I was thinking about the context of the traditional healing and traditional therapies, that they are really traditional and not necessarily the entirety of the First Nations cultural view of health. So I was just wondering if some of the people may have thought that they weren't really knowingly using any traditional therapies, but they might have been using their First Nations health interventions on their own, like, for example, an emphasis on lifestyle treatments. I just want to know if you had any comments about that.
We had had a fair bit of conversation around that, and did we ask the right questions? Did we explore that enough in terms of that same issue? And the way that we presented the questions to the individuals was for them to make a decision on their own as to whether or not they were really speaking to or addressing issues of traditional practices. So we didn't kind of provide any triggers or ask them about certain practices. It was what, excuse me, what their perception was. And so we really wanted their understanding and how they saw it. What became very clear to us just through the language that was used was a very medicalized model of their understanding of healthcare. And again, we only got a sense of some of their issues around child health because they really didn't address or see their personal health issues as a priority. But, you know, it's very fascinating. So we kind of grappled with that same issue as well. Yeah, for sure. Sure.
If nobody else wants to talk, I can always figure out something to say. I just wanted to talk a little bit about the role of the Public Health Association in relation to the network, because I think it's an interesting way in which organizations can work together on something around health literacy or other issues as well. So our association has, over the past few years, really got involved in the area of capacity building. And as it turns out, I'm co-chair of the capacity building committee for the Public Health Association, and Marina is the co-chair. And we're also on the steering committee of the Health Literacy Network. And what we've done on our capacity building committee is we've actually developed an ongoing mechanism for capacity building for the public health community in British Columbia, which is spread out all over the province. What we were able to do was, during the summer, we were able to get access to the video technology that UBC has for the medical schools. So they're linking 4 different sites across the province. And so the Public Health Association, 4 years ago, under our kind of leadership, we started a summer school for public health. And it was a 2-day summer school. We had actually 5 sites because a couple people in Smithers wanted to join us, and we did that. We dealt with 1 topic over the 2 days, and it was very successful. And then the next year, we expanded to 4 days, and we dealt with 2 topics over the 2 days. And last year, we did the same, but we actually had 5 additional sites. So we ended up with 9 sites across the province dealing with 2 different topics related to public health. Well, in one of the summer schools, we actually took 2 days and focused on health literacy. So we were able to bring together the public health community in BC, plus the literacy community and others who are interested in health literacy. So we took advantage of the Public Health Association's infrastructure in order to kind of move this coalition further. And other organizations that are part of our coalition have been making contributions as well along the same lines.
Thank you. Sterling has a question.
But I wanted to pick up on Victoria's thing, because I've got this sort of thing that's nagging at me a little bit. So I agree entirely, and I'm learning so much on this about literacy being in context and actually not really being able to say anything about literacy unless you think about the context in which you're talking about it. So my question that I've got in my mind is, so literacy in a health context, is there something different that people mean when they say health literacy compared to literacy in a health context? Because I understand what you're talking about, but that's very much literacy as I sort of, as a layperson, understand the term literacy applied to health. But I think that people are thinking about something a bit different when they use the term health literacy. I think they're thinking about more than that. And I think some clarity on that would actually be helpful for me anyway.
Well, first of all, I don't know if you mean when people say, I mean, there are a lot of people using the term, and I'm not really sure how each one of them is meaning that, you know, about health literacy. I had to go so fast through my slides, but our model of a literacy practice, okay, includes so many things like values, beliefs, power, and those are constraints, or they contextualize everything inside. Then you have social purposes. What social purposes are you meeting through this health literacy practice, and that you need health literacy to meet them, and the function it's serving for you, and so on. All of that, to me, is a literacy practice. And health literacy is one literacy practice if you're going to think about it in terms of within social domains. Okay, there's different ways of cutting that pie up. But that's probably not the way a lot of people, I don't know about you, but a lot of people think about health literacy. And I think each person or each area of people who are in health literacy think about it differently. What I'm just sort of being an ethnographer as well, picking up, is that what's common across how many people use the term literacy, especially when they get to assessment, is that they're thinking about the ability to read and write outside of a social context, right? So even if it was to say the ability to effectively to meet your purposes within a health context, that's health literacy. That to me would be a more valid way of looking at the construct. But I also think that that's the product of, it's not just people in health or health literacy that do that. A lot of people do that. You know, they think about, first you learn to read and write, then you can read to learn. That was a real simplistic thing many years ago. So there's a lot of reasons for that. But does that sort of answer your question? And I think it takes a while that's why I use the story of my son with, are all living people in time. I mean, it takes a while to get that relationship of what we think of as literacy, you know, sort of being able to communicate through print or through oral language, as being embedded within something. And therefore, its very meaning and use and shape is shaped by what it's embedded in.
Well, I just want to comment on it, on this issue, because it's one that we've struggled with in terms of developing this area of work. I actually buy what you're saying. That really, but there is something very unique about the health context, and for that reason, I think we have to approach it somewhat differently than we might approach it in other areas. You know,
but that's my point.
Yeah,
that's my point. Exactly.
Yeah, exactly. And so and I think where our workshop this week has gone is moving up from looking at the individual in the health context to looking at the system and looking at the professionals and practitioners that work in the health context. And health literacy is really an interaction between the individual who's receiving services or receiving information and the professionals or practitioners that provide it and the systems that support those practitioners. And that in itself is a big chunk to deal with. And if talking about health literacy helps them do that better, that's great. That's really what we're looking for.
Yeah, I don't mean to say that we shouldn't think of health literacy. You know, I guess I'm saying exactly what you're saying. You know, so like we could have a conference on financial literacy, and it would be sort of the same kinds of issues, the systems, the power, the values, the beliefs, the ability to make sense out of the stock market reports and things like that.
So I guess I don't know if I have the honor of bringing this session to a close. I want to thank you all very much. I think that at the end you fed in some extraordinarily important strands of conversation that we really have not, or are not going to have the opportunity to pursue. And I think it's a shame that we didn't get these in earlier, because I think a good part of the discussion we could have had over the past 2 days would have been around the way these various views and comments intersect. But I think just bringing in the participatory point of view, the concept of literacy is being situated. I mean, I think if we leave with some, at least either an agreement or at least a question, right? Even a question about the extent to which we need to interrogate some of our own assumptions and concepts on which we're basing our actions, that won't be a bad place to end. So thank you.
I want the cameras not to focus on me, but to focus on Peter Wall. Because if it wasn't for Peter Wall, we wouldn't be here. And what a great example of philanthropy. You know, I don't know what Peter Wall decided when he woke up. He must have given a lot of money to endow this institute, because our activities alone. Anyway, I just wanted to focus on that and thank Peter Wall. I don't know whether Joanna's still here and anybody from the institute, but anyway, they've been amazing, supportive and very helpful in terms of putting together the program. This is the first health literacy sort of endeavor I've been formally engaged with, but the kudos, the godfathers and the godmothers of health literacy tell me this has been one of the best workshops they've attended, so I'll just accept their reflection on that. I have no others to judge by, so I couldn't judge by the fact that this personally for me has been very successful. And the other reason I stand over here is just to read, and I'll read it because you won't be able to read it from where you are. Providing resources for the capable and committed individuals to follow their instincts leads to the best of all discoveries, the totally surprising, the most unexpected, and the most useful ones. And that's by the late Dr. Michael Smith, Nobel laureate, Peter Wall, distinguished professor, and a former professor at UBC. And I think that to me is a nice statement. Some of you know I've been involved in developing an Institute for Heart and Lung Health in UBC, and Max Sinider is the sort of scientific director of the Brain Mental Health Centre. But I think we got Max to come to talk to one of our sort of early development sessions, and Max coined the term that I had maybe for the first time heard, creating opportunities for collisions. And I was that seemed a bit disjointed to me when he said it first, but it was really about meeting people and meeting people in the hallway that you mightn't otherwise meet. And I think this to me has been about creating collisions, about people coming with preconceived notions. I'm also told by one or two of the attendees of the health literacy circuit, for want of a better term, that usually these workshops can be more what's the word? Combative, maybe a good term. Somebody said, I don't know, this is sort of street talk or coffee talk. Maybe they're all urban myths. But anyway, so I hope we've managed, I think we've managed. And I think also just in the medical model here, like I know Nadia and I know Tricia and I know Scott and I know the work that Rick Lester presented on a couple of days ago. And even with our own medical model, we're also busy and we're bright, successful people. We don't actually get an opportunity to cross-pollinate. So I think we have had an opportunity to cross-pollinate here within our own individual streams, but I think more broadly in terms of health literacy and literacy in general. So the slide says future direction. So before we go maybe to that, I just want to thank Iraj. I have to give Iraj the most thanks because Iraj is sitting beside his wife, and I've told her that I will fire him if he doesn't take some time off and not work so hard. It's a terrible thing to have to tell anybody, you know. I don't know whether it's my demonic nature that he feels he has to work, but anyway, I try to get him to work less. But I'd also like to thank Irv, because having no content expertise here, Irv and Iraj were very helpful in giving us some direction on the right people to have here. And from my perspective, we had lots of the right people because they're very bright, very sort of knowledgeable. Sandy was also very helpful in terms of on the organizing committee. And Jessica did a huge amount of practical organizational issues way beyond her job description. So I just want to thank the additional members for that. Ellen at the back has been transcribing, and if she can transcribe the last 2 days as effectively as she did the first 2 days, we'll produce an amazing documentation of our efforts. So I just want to thank Ellen for her efforts. And I also want to thank, it's sort of like a paparazzi here today. I don't know the gentlemen with the bigger cameras, but the gentlemen with the smaller cameras have been tracking us for the last 3 or 4 days. And they've done some great work, both Julian and Jeremy, in terms of putting together the sort of bits and pieces and the sessions and their collage and their key points that they've focused on. It's been really very helpful. So bright young people is what we need. So I personally also would like to thank the sort of national and international faculty, particularly those who've stuck with us right to the end, as it were. I'm sure most of you are used to going to meetings where you fly in, give a talk and leave. That was a very low level of fly in, give a talk, leave about this meeting. Lots of really very busy, very bright people stayed and committed. Many of them had to leave. They took 3 days out of their busy schedules to be with us, and I really appreciate that. And I hope they learned. As I said to a number of people, I came into this endeavor with very low levels of knowledge, so therefore incrementally I had a lot to learn. But I hope everybody learned something. So I'm a sort of a pragmatic doer person. And, you know, I think we have the seeds. I really like Marina's last presentation. You know, I think we have the seeds. You know, we'll show how it's done in BC. And if there are other people from the rest of Canada who want to show how it's done in the rest of Canada, we'll help you. And then we'll take all the bright international people and we'll take the best of their advice and help, and we'll create a global health literacy movement. You know, I really like, Cameron gives these great presentations about social media, and I'm all for creating a wave, create a health literacy wave that will be transformative. So I just want to thank everybody. We'll work on facilitating to the best we can the process of moving forward. And that's a fluid process. Everybody is busy. We'll give people opportunities to participate further, and I look forward to collaboration. So finally, I'd like to thank the broader community for coming. I was amazed, actually, that there'd be anybody here on a beautiful, sunny spring weekend. I think it's quite impressive that you all take time out, but at least the next week is supposed to be sunny. So enjoy the rest of the afternoon, and safe travels home for those who are traveling onwards. And we hopefully will meet again in another venue and build on the great work. So thank you very much.